Thank you all for coming. Welcome to our new medical education building, and welcome to everybody who's watching or participating online. We have a really exciting program today. We're going to start with some basics of Parkinson's disease, and then we'll have a panel of experts. So please think of some questions that you might want to ask about maybe sleep or gut health, things that are related to Parkinson's or healthy aging in general. And then we're going to learn some about some genetic studies. We're going to learn about environmental interactions and plenty of room for questions. So please, if this is for you, if there's anything that you want to know, you came here, please ask so that we can make sure that you get what you wanted. The other thing is that we have a raffle. You all filled out a raffle ticket, and I think we should kick it off by pulling some raffle tickets. What do you think? This is Star. She's from Grambling. She's in the social work program, and she's in charge of the raffle. All right, go for it. Pick one. Let's pull, how many should we pull today, right now? Three? How about three now, and we'll work our way up to six. Okay. 0585 is the first one. Hugh Sparkman. Awesome. All right, so these are for t-shirts, and what you should do, Hugh, is, and everybody who wins, is the t-shirts are down at registration, so just go down there and say, I want a t-shirt, and they'll have your ticket, and you'll get to pick what size you want and everything like that. Okay. Excellent. 0617. Okay, she's not up here yet, but we will. Okay, we will find her. Okay, Hilly Pollock, if you see her and know her, tell her she won a t-shirt. And 0633. Stephen Woodfin. Okay, y'all want a t-shirt? Stephen, you want a t-shirt? So at the break, there's a nice long break. You can go down to registration and pick up your t-shirt. We'll have it ready for you. All right, are there any questions before we get started? The gentleman who will know that is sitting right behind you. Under your chair. For anybody who needs a plug, it's under your chair. All right. So I'd like to introduce Dr. Abbas. He's going to talk to us about the basics of Parkinson's disease. He's a neurology resident here at LSU, finishing up his training, and he has a special interest in Parkinson's, as do all of us. So please welcome him.
Hello everyone, good morning. So I'm going to give brief introduction to Parkinson's disease. This will set the stage for the next lectures coming today. Okay, let's begin. So we will start with some historical background about Parkinson's disease. The first physician who described this disease is James Parkinson, who's a British physician, and initially he wrote an essay called Essay on Shaking Palsy, and then the disease was named after his name. That was in 1817. Then the next step in Parkinson's disease discovery was done by the German pathologist Friedrich Lewy. That was in 1912. He reported the presence of Lewy bodies, which are these pink inclusions inside the neurons. And they were named after his name. Then the third big discovery was made by Tretkov. That was in 1919. He discovered that the big change, the big, I would say, abnormality is seen in substantia nigra that's located in the midbrain. This is where Parkinson's disease hit the most. So, and then in the 1950s, we discovered the importance of dopamine in the pathophysiology of this disease, and that dopamine depletion in the basal ganglia plays an important role in the pathophysiology and pathologic changes of this disease. So, let's shift to epidemiology. The incidence of Parkinson's disease and the prevalence of it are increasing. In the US right now, we have 1% of people above 60 have Parkinson's disease. And then the average age of onset is 60 years old. There is mild male predominance, 1.4 to 1 male to female ratio. So our risk factors for PD, we have age, as we mentioned, and then male sex, as we mentioned. Then there is some genetic predisposition. The genetic role could be either one gene that leads to the disease or multiple genes that predispose the person to develop Parkinson's disease. Around 15 to 20% of Parkinson's disease patients are inherited. It could be either autosomal dominant or autosomal recessive or X-linked. And then the other risk factor is the environmental exposures. We have variety of environmental stuff can lead to Parkinson's disease, either pesticide exposure, air pollution, and then industrial stuff like heavy metals, copper, manganese, or lead. Then the use of well water, living in rural areas, farming or agricultural work, then solvents, and then something interesting that high consumption of dairy products can lead to Parkinson's disease, can be a risk factor for Parkinson's disease. So the pathophysiology of the disease in general, that we have progressive degeneration of dopamine-producing neurons in substantia nigra that's leading to the dopamine depletion in the basal ganglia. So this is a figure showing us that down the figure we can see substantia nigra, which is where the dopamine-producing neurons are getting depleted in our brain, which reduce the dopamine availability in the basal ganglia. And then this is another image about the pathology of this disease. So on the left, we can see a normal brain. We have this black area in substantia nigra, which is the dopamine-producing neurons. And then in Parkinson's disease brains, we can see the loss of these dopamine-producing neurons in the midbrain. So this is another picture of the pathology of this disease. As we mentioned earlier, there is inclusions of these pink bodies, we call it Lewy bodies, that lead to progressive disease. So shifting to clinical presentation of the disease. So we have something called prodromal symptoms. These symptoms can start any time, like from months to years before the motor symptoms of Parkinson's disease kick in. These prodromal symptoms, the main three prodromal symptoms are REM sleep disorder, and then constipation, and then hyposmia. So REM sleep disorder is a kind of disorder that patients will act out their dreams. Usually when we have a dream, our muscles should be relaxed, but these patients will act their dreams, so they will have violent movements, yelling during their sleep. Then constipation, a very non-specific symptom, but can start years before the onset of motor symptoms. And then the other symptom is hyposmia, which is a decreased sensation of smell. Then, after that, we have the cardinal features of the disease, which are 3 cardinal features: bradykinesia, rigidity, and tremor. The first symptom is tremor. Usually we call it resting tremor, which means it happens when the patient are just resting their arm, not doing any activities. Usually start in one hand, and then it will spread to the other hand, and it can spread to other body parts. And then the other cardinal feature is bradykinesia, which means slowing of movements. Patient movements will become slower. So this symptoms is difficult for patients to describe. They may describe it as a difficulty to doing manual activities with their hands, and then they will feel that they are dragging their feet when they walk, and feeling of unsteadiness. And the third cardinal feature is called rigidity. This is more of a clinical sign that we can discover on physical exam, which means that when the patient is not doing any movement, when we try to move their arm or leg against any joint, we will feel increased resistance to our movement. So their muscles are kind of stiff. In addition to the motor features, Parkinson's disease can cause a lot of non-motor symptoms, like hypomimia, which means that their facial expressions will be decreased. And then hypophonia, that their voice will be soft. And then micrographia, which means their handwriting, when they write, the letters will become smaller. Then dysphagia, difficulty swallowing. Then stoop posture, when they walk, they will be leaning forward. Dystonia, and then freezing of gait. In addition to the motor features, there's a variety of non-motor features, like some neuropsychiatric symptoms, some depression, anxiety, and then cognitive decline. Late during the disease progression, Parkinson's disease patients can develop some memory loss, some cognitive issues. And then we have the autonomic features, like orthostatic hypotension, some constipation, some urinary symptoms. And as we mentioned, sleep disorders, they can take the shape of REM sleep disorders, or a different kind of sleep difficulties, some insomnia, some excessive daytime sleepiness. So, how do we make the diagnosis of Parkinson's disease? Usually we make the diagnosis clinically, or taking good history from the patient and then good physical exam is enough to make the diagnosis clinically. We don't have to make, technically in clear-cut cases, we don't have to make any additional imaging or investigations to make the diagnosis. So this is the diagnosis during lifetime, but if we need to make definitive diagnosis, it's definitely done by autopsy, post-mortem autopsy. We have some ancillary testing that we can apply in patients with unclear picture, but they are not necessary for each case. One of them is called DAT scan. It's kind of nuclear imaging. We inject some active radionuclear substance using peripheral IV line, and then we check the uptake of this material in the basal ganglia. If there is reduced uptake, which means the patient has some kind of degenerative Parkinsonism. And then we have the skin biopsy. These Lewy bodies that accumulate in the brain, they accumulate in addition to that in the skin of these patients. So we can use skin biopsy to look for Lewy bodies. And then we can check for protein called alpha-synuclein, which is the protein that constitute Lewy bodies. We can check it in blood or CSF. Okay. Then what differential diagnosis we have in patients presenting with symptoms concerning for Parkinson's disease? The main differential is a disease called essential tremor. We can find some differences on physical exam. Essential tremor patients, usually they don't have the rest of symptoms of Parkinson's disease, like the slowing of movements, the other symptoms that they have. And then there's another types of, we call it atypical Parkinsonism, which means our Parkinson symptoms, in addition to that, these patients have additional features, additional symptoms. These disorders are much less common than Parkinson's disease, like Lewy body dementia, CBDs, MSA, and PSP. And then we have drug-induced Parkinsonism. Sometimes use of some medications can provoke symptoms. They look like Parkinson's disease, but this kind of symptoms can go away after discontinuation of the medication. And then we have vascular Parkinsonism. These patients who have chronically uncontrolled hypertension, diabetes, can affect the basal ganglia and cause symptoms similar to Parkinson's disease. And some infections can also affect the basal ganglia to cause similar symptoms. Now, we can move to treatment. Actually, till now, we don't have what we call disease-modifying treatment. Like, we don't have any medication that can halt the progression of the disease, but all the medications that we have right now are just for symptomatic treatment to control the symptoms that the patient have. So as we mentioned that dopamine loss is the main pathophysiologic feature in these patients. So levodopa formulations will be the main medication for these patients. This medication can take the form of oral, or in advanced cases can be given subcutaneous or inhalational or intestinal gel. But the vast majority of patients will be taking only oral forms. In addition to levodopa, we have some medications that can affect the metabolism of dopamine. Some medications will decrease the destruction of dopamine, like MAO inhibitors, COMT inhibitors. These medications can be used in addition to levodopa or sometimes used alone, depending on patient case. And then in severe cases, we have something called DBS, which is kind of a surgical procedure. It's mini invasive surgical procedure in advanced cases. We can stimulate the basal ganglia to help these patients. And then we have infusion therapies. They are also for advanced cases, where levodopa can be given using intestinal gel, or something called subcutaneous apomorphine infusions, or some form of levodopa given using continuous subcutaneous infusion. And then we have also treatments for the non-motor symptoms. As we mentioned earlier, they have the depression, the cognitive issues. We have to treat, or we have to address these kind of symptoms too. Then the disease course. Actually, Parkinson's disease, despite being a disabling disease, it will not affect mortality that much. So Parkinson's disease patients are expected to live as much as patients without Parkinson's disease. It will affect mortality only modestly. It will be increased 1.3 to 1.5 compared to their age-matched people. The most common cause of death related to Parkinson's disease will be aspiration pneumonia, because over time they will develop difficulty swallowing, and they might have some lung infections because of that. How much of these patients will be wheelchair bound? We expect 30 to 40% to be wheelchair bound after 15 years, and then dementia can develop and up to 46% at 10 years and 83% at 20 years. And that's it. Thank you for listening.
Are there any questions? Here, let me grab the theory. Here, I'm going to let you ask in here because there are people online and I get to be Donahue.
Oh, okay. Can we get printouts of these slides and
Absolutely.
your presentation?
Yeah, absolutely, yeah, sure.
Yes, ma'am.
Thank you. Great presentation. When you spoke about the continuous infusion as one of the treatment modalities, is that through some type of port? Is that home treatment, or is that just in hospital or in some type of facility treatment?
Yeah, this is home treatment actually. So some infusions, the intestinal gel, they will place a kind of peg tube, we call it. So the tube will be directly giving the medication to the duodenum directly. So this is one infusion, and then the subcutaneous infusions, they will have a pump. It will be started, and then the medication will go home. The pump will gradually just give the medication at home continuously. So this is a home medication, yeah.
Parkinson's disease, and someone doesn't necessarily have all the symptoms, or they only have a tiny bit of symptoms, do y'all ever do any kind of the skin biopsies or any of the genetic
sure, yeah.
testing ahead of time, even though they don't have the illness?
Mm-hmm. Yeah, exactly. In cases where we're not sure that it's Parkinson's disease, yeah, it's always good to do the ancillary testing, like the DAT scan, skin biopsy, CSF markers. Yeah, definitely. Yeah, we can use it in cases we're not sure that this is Parkinson's disease.
Thank you. It's very thorough and a lot of information that we need. There's a difference, we think, and I'm talking about community members, between Parkinson's and Parkinsonism, or at least we hear that. What's the difference, and what difference does it make for us in the community living with one or the other of those labels?
Mm-hmm. Yeah, thank you for the question. So, as we mentioned earlier, our known Parkinson's disease is the most common one of these disorders. Patients who has Parkinsonism syndromes, these patients will have additional features. So, for example, one of the Parkinson mimics is dementia with Lewy body. So in these patients, we expect early onset change in their cognition, memory issues that will kick in within 1 year of onset of these symptoms, and then we will expect them to have more of visual hallucinations. And then we have like different type of Parkinsonism called PSP, primary progressive supranuclear palsy. So these patients, we are expecting them to have more falls toward the onset of the disease, and they will be less responsive to our medication, to dopamine repletion. So, and then these patients, their daily activity will be more affected than our known Parkinson's disease patients. So it's important to make this differentiation because it will affect our treatment and what kind of symptoms we will expect from these patients. Is that good enough?
Can I follow up with another expansion on that?
Mm-hmm, sure.
Thank you. In the community, if I hear Parkinsonism, I'm going to think, oh, that's not as worrisome. I shouldn't worry as much if I have Parkinsonism or if my husband has it, as if I have Parkinson's. It sounds like what you said right now, that Parkinsonism is maybe a little bit more worrisome.
More worrisome, actually, yes, exactly. Yeah.
One quick question that you may be able to expound upon. You said the most definitive diagnosis is post-mortem. Is there something that shows up post-mortem that does not show up while they're living?
Yeah, so post-mortem, I mean, we can do the brain biopsy itself, so we can see the brain itself under the microscope. We cannot do that during lifetime because we can skip this procedure. We can make the diagnosis based on our clinical exam and then on typical history. If needed, we can do the ancillary testing, but we don't have to do the brain biopsy during lifetime, you know. Sure.
Hi, good morning.
Good morning.
Great presentation, thank you so much. So, wanted to ask about, you were discussing drug-induced, Parkinson-related issues. I assume, or maybe incorrectly, that would be tied to things like TD, because of perhaps antipsychotic and other types of medications. Is that fairly accurate?
So it's not quite accurate because TD is something different.
Okay.
Yeah, but yeah, antipsychotic medications can cause Parkinson disease
Yes.
and Parkinson symptoms, sorry, and then antipsychotic medications can cause a TD. So TD is different kind of symptoms that caused by antipsychotic medications, and then the treatment and the clinical course will be different between TD patients and drug-induced Parkinsonism. Yes, usually we expect if it's drug-induced, we expect the patients to improve and recover within like 6 months of discontinuation of the medication.
Okay, so then in that, as a follow-up, then within that, then I guess the telling, whether it's one or the other, I guess the the telling of that would be time, right? Is that pretty accurate?
Actually, the time and the type of symptoms. So
Okay.
TD, usually the symptoms will be kind of dystonic symptoms. They will have continuous mouth movements, tongue movements, involuntary, these kind of movements, dystonic movements. So, but they will not have the whole picture of Parkinsonism. The slowness of movements, the rigidity, so the tremors. So TD patients will not have the whole Parkinsonism picture. Okay.
Okay.
They will have some, we call it dystonia, some specific features that are different from Parkinsonism. Yeah.
I see. Okay, well, thank you. Thank you
Yeah,
for
sure,
clarifying.
Sure, sure.
How much does consistent exercise help in the absorption of the medicines that a patient would be taking for Parkinson's? And secondly, for a patient that's very regimented and takes the medicine at specific times to the minute, if she doesn't have the symptoms at the particular time that she's supposed to take it, should she still take it at that time, or should she wait for a symptom to present itself?
I see. So the first question, we always recommend exercise for these patients, but I mean, our recommendation of exercise is not for drug absorption. It's mainly because exercise can at some point relieve these patient symptoms, and there is very mild evidence that it can delay the progression of the disease. But our recommendation for exercise is not particularly to hasten or to improve drug absorption. Okay. Then the medication adjustment. I mean, our medication are symptom triggered, so definitely medication should be tailored to patient symptoms. I would suggest always, like, for the patient to check with their neurologist, see if the symptoms are well controlled on this dose. Do we need to make any changes in the dose? So, as always, like, these medications are just symptomatic treatment, so they should be tailored based on patient own symptoms,
And are there other things that interfere with medication absorption that, like
So
diet?
yeah,
and
that's a
things
good
like
question.
that?
Actually, we usually recommend Parkinson patients if they are taking levodopa, to be away from protein-high meals, because levodopa is an amino acid. So if they are taking any meal that is heavy in protein, they will interfere with the absorption of the levodopa, and that will decrease its absorption. So usually avoid taking heavy protein meal around the time of taking your levodopa. Yeah.
That was great. Anything else? Yes, ma'am.
I'm just curious because you said something I've never heard before, and that was about the dairy products. What's up with that?
Say it again.
The dairy products you mentioned?
Oh yeah, yeah, that's weird actually. Yeah, yogurt, milk, stuff like that. I mean, it's kind of statistic correlation. We don't know why this is happening, but it's statistically it's mentioned that heavy use of dairy products can increase the risk of Parkinson's disease. Yeah, that's weird actually. Yeah, I mean, we always recommend dairy products for to replete calcium and everything, but I think heavy use of these products can statistically increase the risk of PD. Yeah, and then on the other side, drinking caffeine has good preventive role against PD. So caffeine is good. Dairy products are not much. So yeah, yeah, that's weird actually. Yeah, but I mean statistically, it's there. Yeah.
Can you say what you mean by heavy use?
Yeah,
Please define heavy
I mean,
use.
I know there is no clear cut in these situations. Yeah, I mean, I don't have like quantification to tell you about, but it's yeah.
Yes, ma'am.
Is there a specialist that deals with nutritional counseling and constipation, nutritional counseling and the protein? And
Say
how
it
the
again. I'm sorry.
medication can affect your symptoms?
I'm sorry. Say it again.
Is there any nutritional counseling that deals with protein and how it affects your body, or the constipation?
Oh yeah,
Oh.
yeah, definitely. So this patient, constipation is common in these patients. So we need, they have to take more fiber diet, and then if they are still constipated, we can add some medications like Miralax, stuff like that, so that can address their constipation. Yeah, yeah. So increased fiber diet fiber content will be very helpful in these patients. Yeah.
Great questions. All right. Thank you, Dr. Abbas.
Sure.
Yes, okay. And he's going to stick around for the panel, which is coming up next, too. So there's not a time limit on.
Okay.
Yeah.
I have been to a neurologist for what I think I've got Parkinson's symptoms of it, but he told me I did not have. But according to my little investigation at Mayo Clinic, I have 6 of the 8 symptoms that they list. Where do I go from here?
So it's always good to revisit the diagnosis. Maybe when you saw your neurologist, there were like early symptoms, the clinical exam findings were not clear. So it's always good if the suspicion is still there, we can revisit the diagnosis, consider it again, and then it's always a good idea, if we are not sure, to do some of the ancillary testing, ask for the ancillary testing, like the DAT scan imaging or the skin biopsy, CSF markers, spinal tap. Yeah, I think if we have still suspicion, we can always do something else to check, to make sure that we don't have it. Yeah.
And I will say, I realized I didn't introduce myself, but my name's Elizabeth Disbrow. I'm the director of the Center for Brain Health, and we have a table downstairs of informational things about resources and everything. We're going to hear a talk about them, but we have 2 relatively new movement disorder specialists in Shreveport that work here at Ochsner LSU Health, and their contact information is down on that table. So when we have our break or lunch, we have a nice long break and lunch, please go to our table. We have all sorts of information, and our number is on there for the Center for Brain Health. and you can call us with any questions. We'll help you navigate the system and get to see Dr. Abbas and his colleagues for any of these tests that you are
Happy to help.
have questions about.
All right.
Good.
Anything
Oh,
else?
I may have missed it, but is there any prevention or any precautions where Parkinson's disease is concerned? And my reasoning, basically in the African-American community, when, you know, we always end up being disproportionately affected by disease, are there any early detections and prevention things that, you know, you can do where Parkinson is concerned?
I didn't get it. Can you say? I didn't.
I said early detection or
Early
prevention.
Yes.
Yeah.
Yes. So early detection, I mean, unfortunately right now we don't have a disease-modifying therapy. So early detection will not make big change, I would say, because we don't have a lot to offer for these patients. Definitely, if we transition to an area that we have medications that can stop the progression of the disease, so early detection will be very helpful. But the only thing that we always like, if there's any early signs of Parkinson's disease, if we don't want to try any medication, we can recommend physical exercise, because physical exercise is the only thing that has some mild effect to like change the course of the disease. So physical activity, physical exercise, we can recommend that in early stage. If the patient's symptoms are very mild, that he doesn't need medications to begin, yeah.
and on the research side, there are a lot of drugs in development that are disease modifying. I mean, we're getting calls about them all the time from drug companies to participate in studies. So I'm a researcher, so just to plug for research. So those are coming, and there is the biomarker test that he was talking about for the alpha-synuclein. That's new, and I think that's going to become commercially available, which is an early detection test. And so I'm kind of giving myself chills, but in the next 5 to 10 years, we should be able to see early detection, like you can get a test at your doctor's office with disease-modifying precision medicine. That's the goal, and it's a lot closer than if we'd had this meeting 5 years ago. I would have said, I don't know, but I think it's really coming now.
In this area, are there any disease-modifying clinical trials that a participant can participate in?
We are not doing them yet. They're very invasive, and they're sort of early stage in the drugs, and so we have not signed up for them yet, but stay tuned. And there are trial finder software like the Michael J. Fox Foundation has, and the government has them, and yes, we are, a lot of them are not local. But that's changing. I mean, it's not gonna change by next week, but we have been looking at trials that we can, that are, the risk to benefit ratio is correct, and the amount is favorable, and the amount of effort for the patient and for our team is something that we can realistically do. And so we are actively shopping for some of these trials that we can bring to our area. Okay, excellent. Thank you so much. All right, you can stay here, Dr. Abbas, because we're going to do the panel now. You thought you got to be done, but not quite yet. First, let's do it. Why don't you let Dr. Abbas pick a ticket for the raffle? Yep. Okay, the number is 0639. Anybody? D. Evan, it says. All right. Okay, good deal. Sure, let's do another one. Why not? Live dangerously. All right. 0596. Yes, okay. Good job. All right. So now the panel, we have a moderator from the NAACP, who's going to help us get through some more questions and some more of your questions. And her name is Shy. You want to come on up and tell us a little bit about yourself?
Good morning, everyone. Thank you guys for putting on such an amazing event. I think today is going to be very, very, very helpful for the community. My name is Shanitra Shaw. I am an East Texas native. I'm from Longview, Texas. I am the NAACP Communications Chair. I don't think they can hear you. Oh, can you hear me now? Better? Awesome. Let me start over. Welcome, everyone. I think today is going to be an amazing event. And before I do just introduce myself, before we start, I want you to already get to thinking of some questions that you may have for the panel. But again, I am an East Texas native from Longview, Texas. I'm also the NAACP Communications Chair of the Chapter 6197, also of Gregg County. Not to mention, I am a retired medical professional. In 2023, I took my hat off, but I still have a passion for serving. I still have a passion for knowledge and providing information to my local community. So with that being said, we're just gonna kind of jump on into some questions here that we have for Dr. Abbas and the other panelists here just as well.
We'll introduce the folks.
Sure.
Let's have these, they can introduce themselves. How about that? Want to introduce yourself?
Okay, sure. Hi, everyone. It's so nice to see everyone here and online, and we had, I think, a great talk. So I'm Sheila Asker. I am a pediatric neurologist, so, but I'm also, I practice sleep medicine. And I'm very interested in sleep changes in neurodegenerative disorders like Parkinson's and Alzheimer's. I find that interesting. The other thing that I'm very passionate about is I love to talk about sleep deprivation and how that affects the body. How does it affect cognition? I'm also interested in sleep apnea. And these are things that I enjoy educating my residents, my medical students, and my patients, because this has far-reaching effects, as you all know. So that's me in my free time. I am devoted to my 2 canine kiddos. I spend a lot of time with them, Ori and Abby, and I am a big environmentalist and want to end cruelty to all animals. So that's enough about me.
All righty. So I am Evelyn Pryor. I am from Atlanta, and but my grandparents are from here. And I have been with the medical school for almost 5 years. I am the chief of general internal medicine, so we focus on providing excellent preventative and primary care to the community. And I'm also, I teach in the medical school, and I'm one of the program directors for the residency program, the internal medicine residency program. And so my research background started off in hypertension, and now I'm working with Alzheimer's and Parkinson's disease. We recognize the importance of clinical trials and of representation in clinical trials. In my free time, I'm also the chief of population health, and this is where we make big changes. We have the mammography vans that go around to rural areas and try to provide access to cancer screenings, including colon cancer, breast cancer, and cervical cancer. And I guess I'm like, what do I do in my free time? Not as much. I have 2 kids, and I'm married, and so that takes a lot of time.
Good morning. I was in the wrong room. I thought we were. I thought, well, no one's here. Good morning. Thank you for being here. I'm Marie Vasquez Morgan, and I'm a clinical associate professor in physical therapy here at the school. Been doing so for about 31 years. I also serve as the director of institutional wellness, looking toward all dimensions of well-being, including physical, of course, nutritious, well-being, financial, social, digital, just a host of different dimensions for the whole campus. I have an active practice still in our faculty practice clinic where I see patients with Parkinson's and a host of other mostly neurodegenerative diseases. And I'm very happy to be here to be part of this panel today.
Awesome. Thank you to our panelists for being here. Let's get started with the conversation about what Parkinson's really is. First question is for Dr. Abbas. Is there anything we can do to reduce the risk of PD? I think you kind of covered it, but that's a specific question.
Hello again. So, you know, we mentioned earlier that there are some stuff that we cannot change, like being older, male, sex, have higher risk to have the disease. And then there is some genetic factors. We cannot change this stuff. But what we can change is the environmental exposure. You know, as we mentioned, that exposure to heavy metals, pesticides, using well water to drink, and then stuff like chemical stuff like solvents. All this kind of stuff can predispose to Parkinson's disease. So trying to avoid this stuff is helpful. And then, as we mentioned earlier, modest use of caffeine is helpful to prevent PD. We cannot recommend high dose of caffeine because, you know, there's always side effects with caffeine. So, but modest use of caffeine has a preventive role in these patients. Then, medication-wise, we don't yet have medication specifically to prevent PD, but clinical trials are running. There is some conflicting data about some diabetes medications, like dapagliflozin, one of the medications for diabetes. There is some data that it can have some preventive role. Even like ibuprofen, NSAIDs can have some preventive role, but none of these medications is technically approved to be used for this indication. So right now we need to focus on environmental exposure and then exercise, some caffeine use. These are the behavioral changes that we can do right now to prevent PD. Okay.
One more question for you, Dr. Ashgar. Dr. Abbas. How much of Parkinson's risk is genetic versus environmental? Oh. Sorry, how much of a Parkinson's risk is genetic versus environmental?
So initially, the initial studies said 10% is genetic related, but now studies right now says it's up to 20% because, I mean, as we discover more genes, so we know more right now that genetic factors play a role. So right now, up to 20% are genetic. Yeah, and then, I mean, there are some trials running specifically to reverse these genetic factors, but as we mentioned, nothing came to light for like to achieve to be used on regular basis right now.
Dr. Ashgar. Dr. Ashgar, is sleep disturbance linked to PD?
Would you repeat that again?
Is sleep disturbance linked to PD?
Interesting, that's a nice question. So the question was, is sleep related to?
Sleep disturbance.
Sleep disturbance related to, or could it possibly increase the risk of Parkinson's disease? So one thing, you know, we know for sure that sleep disturbances such as sleep deprivation does affect cognition in the long run. So what can happen is if you are indeed at risk for Parkinson's and now you have sleep problems, you're sleep deprived, you're not sleeping well, that can exacerbate, and I don't think it can necessarily cause the Parkinson's, but it can certainly aggravate everything. So what happens is that perhaps initially you started off with symptoms with Parkinson, but now you have all these other symptoms on top of it, which makes it far more worse. So I think it has an indirect effect, but I don't think it directly affects or causes Parkinson's per se.
Thank you. One other question. What is sleep apnea, and how is it linked to cognitive decline in seniors? And if you can just kind of keep it in layman terms for us, that'd be great on sleep apnea.
Okay. So I love this question, it's awesome. So we all know what sleep apnea is, but let me just go through that because it's so important. So sleep apnea simply means stopping breathing. So something is making you stop breathing. In little kiddos, it's usually big old tonsils. It obstructs the airway and boom, you stop breathing. Now, in adults, it becomes interesting because what happens is usually there are a number of different factors which can cause you to have obstruction to your airway. One is you have laxity of the neck muscles. That can occur as you age, and so when you're sleeping, that kind of obstructs your airway. And we all know in the South, we love good food, we like to celebrate, so some of us are a little bit hefty. So when you have a little bit more, excess skin and weight that is compressing your airway at night, that increases your risk of obstructive sleep apnea. And then lastly, of course, we all also enjoy good food, and some of us like to have a nice drink as well. So if you have drinks or you're taking medications, sometimes that can cause the muscles also to be a little lax when you sleep, and that increases your risk for obstructive sleep apnea. Now, what was the next question? I forgot.
That's okay. Is it linked to cognitive decline in seniors?
Oh, yes, okay. So the interesting thing is naturally, if you're not breathing, the moments when you stop breathing or you have the apneic episodes, what happens? So first of all, your body, we have a beautiful body that God created because our body tells us, hey, you have to breathe. You've got to do something. And so you have this arousal after you've stopped breathing. And when you have the arousal, a lot of things occur. Suddenly, your heart rate goes up, blood pressure goes up, because you're arousing, you're trying to get up. And when you get up, boom, you take that deep breath. However, if you're doing these arousals multiple times during the night, what happens is over time, that can cause inflammation. You can have neuroinflammatory markers that increase, and over time, it can increase the risk of you having now florid obstructive sleep apnea. And what happens is because there's less oxygen coming, it does affect your cognition, because a lot of times it'll affect your hippocampal area, your medial temporal area, and what happens is those areas are very important for memory. So if that affects those areas, then of course you're going to have trouble with memory, with remembering things, retaining things, and so those are some of the things that is caused. So it's not just the stopping breathing, but it's the arousal or the protective mechanism that your body has. Over long term, that may cause and disrupt everything. I hope that answered the two questions.
Yes, ma'am.
Okay.
That was wonderful. Thank you, Dr. Ashgar. Any questions so far with these two particular questions?
Do you need the...
I know that there's lots of things we can do for sleep apnea, with the CPAP machine being one of them. But if you still have done all of those things and you still are waking up intermittently, is there a medication that is compatible with the diagnosis of Parkinson's? I've heard that it can affect, sleep medications can affect a person with Parkinson's differently.
Yeah, and that's a sort of a tricky question because sometimes there are medications that invariably are going to worsen some of the symptoms of Parkinson's. So you have to be a little careful. So if the CPAP is not working, then you have to think, well, maybe I need to be on a BiPAP or something else that'll help me sleep better before I add a sleep medication. Because the medication, what it's going to do is, it's not necessarily going to take away the obstructive sleep apnea. Yes, it may help you sleep, but think about it. If we're having obstructive events and we continue to sleep because of a medication, it's just going to worsen things. So that's
Gotcha.
something, yeah, that needs to be addressed. And this day and age, we have all kinds of machines that can actually help you breathe better in the event that the CPAP doesn't work. Because, you know, perhaps it's something to do with your dental, your mandible, your maxilla, and, you know, maybe a visit to a dentist might help as well. Perhaps you have, you know, a big old tongue. Now, I know you can't clip that away, but there are things, maybe exercises or something like that, and there are devices recently that have come, like Inspire device that people are using to try and help with the obstructive sleep apnea. I hope that, you know, answered your
Yes,
question.
it does. And what percent of Parkinson's patients have sleep apnea? Do you know? I mean, is it always
you know,
sleep
I
apnea?
I wrote it down. I was trying to research this morning, but I do know, and I was kind of surprised that in Parkinson's patients, they are at risk for obstructive sleep apnea. You know, they could have undiagnosed obstructive sleep apnea. And we know that if you don't diagnose obstructive sleep apnea, it affects every single organ in your system. I don't know the exact figure. I mean, once we're done, I can check and I can tell you, because I dutifully wrote it in my notebook. I can't remember. But anyway, I hope that answered your question.
Yeah, so that first step is to get a sleep study or figure out if you have sleep apnea. Thank you.
And Dr. Asgar works in a sleep clinic, and you can
Yeah.
make an appointment with her and get a sleep test.
I wanted to know if someone has been diagnosed with Parkinson's disease, do you recommend that they have a sleep study done?
Oh, I love that question. So because, you know, Parkinson's patients are at risk for obstructive sleep apnea, not only that, they have sleep fragmentation, they have these awakenings during the night, they have RBD disorder, then I would say yes. You know, just let your PCP know, and most PCPs, they're very open to getting it done. Do keep in mind that some of these sleep disturbances predate the diagnosis of Parkinson's. Like REM behavior disorder predates Parkinson by 10 years. So it's always good, you know, even if you can get that, you know, polysomnogram, diagnose it, it might just help as we, you know, go along and, you know, other symptoms become more evident. I hope that answered your question. Okay, awesome.
Yes, thank you for taking the time to do this panel today. This question's for Dr. Abbas. So we know that an ounce of prevention is worth a pound of cure, and you were talking about how heavy metals have been linked to increased risk for Parkinson's disease. Shreveport in particular has pretty bad water quality, so do you recommend any like external water filtration system, either at the sink or something that you can put in the fridge just to try to filter out any of those heavy metals or chemicals that might be linked to it?
Yeah, so I mean, that's a good question, actually. I mean, that may be a question to be asked for some like guys taking care of the water and stuff, because I don't know for sure how much heavy metals there in our water that we drink every day. But in addition to the like water that we drink every day, mostly the industrial exposure, if the patient is working somewhere, there is some industrial exposure. This is more linked to PD, but the water that we drink every day, yeah, definitely we need to ask people responsible for that if it's safe enough to drink. They say it's safe enough to drink, but I'm not sure, yeah.
Thank you.
That would be a question for public health, wouldn't it? Wouldn't that be a question for public health?
Exactly.
Right?
Yeah, exactly.
This isn't really a question, it's more of a comment, but we've been receiving notifications through the mail saying that we do have higher than expected ingredients or whatever in our water, but that it's not affecting our health. So I don't know if that helps or not, but.
I was just going to mention the friend of mine that has Parkinson's was exposed to it as a landscaper, so people might want to be aware of what they use in their lawns. But I'm wondering, is there a way, would you test for heavy metal in some of our, patients, or is there a way to test if they're worried that they don't have enough money for water filtration and they're stuck with the Shreveport water?
Oh yeah, definitely. There is. It can be checked. Definitely, there is some labs we can run. Yeah, definitely. Blood labs and some urine labs. Yeah, to check for heavy metals. Yeah, it can be done. Sure. Yeah.
And we do have an expert on environmental links to Parkinson's disease who's going to speak after a little bit later this afternoon.
Yes, my question is the new drugs, the Ozempic type drugs, GLP-1 drugs. I'm hearing that they cause a numbness in the throat, that at night when you go to sleep, that drug has a side effect of paralyzing the back of your throat. I recently was going to have some dental procedures done, and they told me not to take that GLP-1 for 2 weeks before the procedure because it was a risk for anesthesia. So my thought is, what is that drug doing to people? Is it increasing their sleep apnea? Because that's supposedly a side effect that I was not aware of.
I see. I would leave the question to Dr. Alka, but my information that Ozempic-like medications, like there's another one, tirzepatide, is actually indicated for OSA. So it's kind of treatment for OSA. So should be, not causing any sleep-related side effects, but I would leave it to Dr. Asker.
Okay, that one I'm not really sure. What is the correlation between sleep apnea and this particular medication? The only thing I can think of is that if it causes side effects where your muscles are more lax or it interferes in your breathing, then you would be, at risk for obstructive sleep apnea. And we know that many medications have side effects. Some of them are known, the popular ones, but then there are all these little bitty things that could affect people that are unknown, and perhaps that is causing this issue.
Back to Dr. Abbas. Did I say that correctly?
Yeah, Abbas.
I hate to bring up the water again, but we were on well water for almost 40 years. Did you say there's a link?
Yes, yeah, drinking well water, yeah, that increases the risk, exactly, yeah, statistically, yeah.
I would like to go back to when you were talking about movement. Many of us have been diagnosed with ADHD. We have movements all the time, and it is generic. How do you distinguish which is which? Which is, ADHD and which is from the PD?
I see. So, ADHD medications are very mildly linked that they can increase tick movements, which is different from PD symptoms. Yeah, tics are different type of movements. Tics usually, patient will have some urge to do the movement, and then they will get some relief after they do the movements. So stimulant medications that we use for ADHD are not linked to PD, and should be, for the clinician, should be easy to differentiate between tic disorder caused by ADHD, by stimulants, by ADHD medications, and PD symptoms. Yeah, it shouldn't be an issue for the clinician. Yeah.
How about if we move to, we still have exercise in the gut, and we're getting toward the end of our time, and they're both really good topics too, so why don't we move to the, you want the gut? Yeah. Gut next? Okay, the gut's up. And I stole your microphone.
That's okay. We'll make it work. Dr. Pryor, this question is for you. What does PD affect, does PD affect gut health?
Well, absolutely. So Parkinson's disease is a neurodegenerative disorder that affects every neuron in the body. And the gastrointestinal system is everything from the mouth through to the rectum and all of the digestive processes that take place. So Parkinson's will definitely affect the gut because the gut really needs to be, the nervous system of the gut has to work in coordination, so it's very synchronous, from swallowing, the digestion in the stomach, moving the food all the way through, and producing the stool. So when there is a problem with the nervous system, this can affect, like we said, swallowing. I think Dr. Abbas was talking about aspiration pneumonia. If you're swallowing abnormally, you can breathe in food particles that can lead to pneumonia. There can be drooling. There can be problems with the absorption of food itself. So food can, and also medications. So food will not be absorbed properly. Constipation is one of the first signs, and it can also be one of the most debilitating, and it can be life-threatening if it gets to the point of an obstruction. So, and then ultimately, Parkinson's can affect stool production itself. So it can lead to fecal incontinence because people will have decreased sensation in the rectum itself. And then also the de-innervation or the improper working of the neurons that are required to have a bowel movement and to also keep stool in the body so people can have fecal incontinence.
Thank you. Is there a link between high blood pressure and cognitive decline?
Absolutely. So hypertension also affects the whole body, but very specifically, one of the main things that hypertension can do is, of course, cause strokes and microinfarctions, tiny strokes that happen and accumulate over time in the brain and is one of the leading causes of dementia, vascular dementia. So definitely hypertension can cause dementia.
Got it. Thank you. Thank you. Now we know research. Now we do know that research cannot move forward without your participation, definitely from our communities. And a lot of you guys have talked about demographically here about your water, right? About certain chemicals. I know you said you had a family member, a friend that was a landscaper. With that being said, public health. You know, making those complaints, making sure, not really the complaints, but getting the information out, getting knowledge, asking questions, reporting the water, definitely in reference to even those that do have the well water. So just wanted to make sure that what we leave from here today is that we make sure that we ask questions, that we report the information that we see. And what I've drawn from the panel so far, a couple of steps. So number one, you want to seek a neurologist for evaluation. That's pretty much going to be your primary start. Dr. Abbas has kind of given us an overview of some different studies that could potentially take place, so like your skin biopsies and even the sleep studies. Those will be, sounds like to me, those would be some of the two primary things you might want to, you know, engage in as far as getting some treatment. We are up to a break. One more question? Cool.
The new exercise specialty, a group of physical therapists and occupational therapists have taken a exercise training that I want you to hear about before we go.
Thank you so much. So we know that exercise is important for all of us, regardless if we have Parkinson's or not, right? And the current recommendations are for us to get about 150 minutes of moderately intense exercise a week. That means that you can exercise and still be able to talk a little bit, right? That's important for heart health and a host of other things. However, with Parkinson's, what we see in research is that in higher intensity exercise, where you're doing it and you're having a hard time breathing because you're getting really breathy, really increases BDNF, the brain-derived neurotrophic factor that really helps with trying to diminish the motor symptoms and the cognitive problems we have with Parkinson's. It also has shown to slow progression of the disease. So high-intensity exercise is really important. As far as the different types of exercises you've heard of, boxing for Parkinson's, right? That works a lot of the flexibility, the agility, the endurance and strength, which is wonderful. You've heard of big and loud, right? Where we have these large exaggerated movements that assist also to mitigate some of the motor symptoms of Parkinson's. And then power is the one that we were trained on, which is Parkinson's Wellness Recovery Network. And the wonderful thing about this is it's a program that's really based on function, and so a lot of the exercises that we see with power is things that we do on a daily basis. The walking, the sit to stand, the reaching for things, and it also helps with balance, with the decrease or slowness of movement, with the postural instability that we see with Parkinson's. If you go to, I think it's exerciseforbrainchange.org, exerciseforbrainchange.org, you can actually see some of the programs. So you can go to the community, like our faculty practice clinic here on campus. We have several of our OTs and PTs that have been trained in it. I think there's also one other provider in Shreveport, Bossier. But if you are not able to access and go to these things, either because of transportation or other things, other problems that you may have, you can actually get online to do some of these exercises as well. So you can do them from your own home, from your TV. So a great way to try and move some that's really specific to Parkinson's. Can I talk for 1 second about nutrition? Okay, great. Because that's the other thing that I really wanted to talk about. Not only exercise and that high intensity exercise that I was talking about can really help with that BDNF and that really protective factor, but nutrition can as well. So the Mediterranean diet, we know, has been studied for over 3 decades, and it really helps with heart health, but it also helps with neurodegenerative disorders. And so having a nutritional program that's high in vegetables, high in produce, right, high in fruit, especially the MIND diet. The MIND combines both Mediterranean, and you've heard of the DASH diet for hypertension. It combines both those things, but really looking at like strawberries and blueberries that are really high in antioxidants. And these types of foods really increase that BDNF that's really neuroprotective. So these are 2 very preventative things, right, that are non-pharmacologic, non-medical, that we can do for ourselves to really try and decrease the symptoms and also the progression of the disease by moving more every day, if you can, even in 10-minute increments, where you really get breathy, right? But also eating, having at least half your plate be fruits and vegetables on a daily basis, eating lean protein, especially those that come from plants, like lentils or beans, and then having it come from other animal protein like fish that are high in omega-3s. It's also very protective of the brain. Had to put that in.
And I will say that there were plenty of strawberries for breakfast. Right? That was great. Thank you for that, Dr. Vasquez. So we kind of touched on the health and the exercise, right? So
I think we're
good.
good.
For a break?
Yep, yes.
Good deal.
And so our next speaker is at 11. Please visit downstairs. There are some tables from some vendors with aging and Parkinson's related materials, yes, and our table that has a lot of Parkinson's information. Yes, sir.
Thank you. One quick question. What would you recommend for, you come up a couple times about constipation. What's some remedy or pill or something a person can use to help that?
So usually we start with lifestyle changes, more fiber diet and stuff. And then if it's not working, we can add some polyethylene glycol, which is called Miralax. This is usually a stool softener, easy. I mean, it's not, it's very helpful and it's very well tolerated. Yeah, usually these are our medications that we can use.
I think Dr. Fort has something.
Apparently the gut microbiome is messed up in Parkinson's, so there may be special pre or post, probiotics that are a possibility.
All right, if you've won a shirt in the raffle, make sure that you go, and this is a good time to pick it up Just to increase enthusiasm, we've got 0640. Anybody got 0640? Okay. Oh, the name is, Maria Evan, excellent. Keep that. Oh, good. And we've got 0601. 0601. The name is Terri Richardson.
Oh, right there. Richard.
Excellent. Okay, great. So we'll meet back here at 11.
Can you hear me? Hello? I'm on Teams. Can you hear me?
All right. So we're going to change gears a little bit now. I'm going to introduce Dr. Chahine. She is a movement disorder specialist. She is a busy clinician, and she also works with the Michael J. Fox Foundation and some other supporters of a study that we are a site for here. Some of you may have heard of it already. It's called the Black and African American Connections to Parkinson's Disease. It's a genetic study, and she is going to tell us a bit about the results so far, which are really exciting. So I'm happy that we're going to get a chance to hear her. And she is remote, so we will see her slides and hear her voice.
Hi, everyone. Can you see me and hear my slides?
See you, and I can hear you and see your slides. Yes.
You can?
Yes.
Okay. Great. Okay. Hi, everyone. I'm going to be telling you about Parkinson's disease genetics. So I'll briefly give you an overview of the basics of genetics, and then talk about genetics and Parkinson's disease, why it's relevant, and discuss the importance of diversity in Parkinson's genetics research, and tell you a bit about how you can get involved. I know that today you've already learned a lot about Parkinson's disease. As you may have learned, while we don't know the exact cause of Parkinson's, we've learned a lot in recent years, and that knowledge and discovery has been fueled largely by genetic discoveries. In fact, up until 1997, so Parkinson's was first described in the 1800s, but until 1997, it was thought that genes don't play a role in Parkinson's disease at all. And we now know this to be far from the case. There are hundreds of genetic changes in many, many genes that have been linked to Parkinson's disease. So to briefly give you some basics of genetics, first the question is, what is a gene? A gene is a code within our DNA. DNA is found in all our cells, and the genes in our DNA give our body instructions for everything that the body does. So Here we see a diagram. We have all our bodies made of cells. In the cell, there's a nucleus. And there's within that these two strands called chromosomes, and these are made up of our DNA. And in turn, DNA is made up of genes, thousands, tens of thousands of genes. And we have 2 copies of most genes in our body. Genes are passed from parent to child. We get 1 copy from each parent. But our genes also change a lot after we receive them from our parents, and those changes happen just as we get older or due to exposures in the environment or other factors. And genes basically provide the instructions to our cells on how to make various molecules, including proteins. And here, protein doesn't mean like the protein you eat. It's the molecules your body makes. Most of the hormones and other factors in our body are proteins. And we can think of DNA as being made up of letters, like the way letters make up a word. And genetics involves the study of these letters, the study of the DNA, the code in our bodies that tells our body how to function. And so here you can see this representation of these letters where, for example, here the code says ACGA, or TGCT, and if just one of these letters changes in just the right spot, this can have major consequences in our body. Genetic testing reads the genes. It helps determine what the genetic code is in each person, where you can, read it and get A, T, G, you get the specific letters that contribute to the code in the DNA. And so if genes contain the code that tell our bodies how to make proteins and what to do, and there are certain genetic changes in the code, this can give our body the wrong instructions. And so that can lead to proteins that are either faulty, they can be misshapen, they can start getting sticky or not working properly, or the false instructions can lead to the body to make too much of a protein or too little of a protein. As you can see here in this diagram, it can either cause a normal protein to become abnormal or to have too much or too little of it. And this is important because when genetic changes lead to abnormal proteins, treatments can then be developed to target that effect, whether to help improve the protein, to make more of it if there isn't enough, to make less of it if there's too much, and so on. And a really good example of this that many people would be familiar with is that in diabetes, certain genetic forms, the protein insulin is too low, and we can give treatments to we can give insulin to help the body. Now, sometimes a genetic change in the code is so impactful that you only have to have 1 copy of that gene in order to get a disease. Sometimes both copies are needed to get a disease. And when a disease runs in the family, it's usually, there are different forms, but one type, when it runs in the family, it's usually when only 1 copy of the gene is enough to directly cause the disease. Sometimes running in the family is what we consider hereditary disease. And so there would be a code in the DNA that is causing a disease, and many families carry that code because, again, it was passed on from their common ancestors, from grandparent to parent, and then parent to child, and so on. Now, 10 to 15% of people with Parkinson's have a clear genetic cause, a gene causing or strongly linked to Parkinson's. But that's if you take all people with Parkinson's, but there are certain people with certain ancestries who are much more likely or even less likely to have genetic codes that are directly linked to Parkinson's disease. Our genetic code can cause or contribute to Parkinson's, though, even when we don't carry those very impactful genes. So another way to say this is that we can think of 3 different types of genetic changes that contribute to Parkinson's. Either you have that single gene that carries a very high risk for Parkinson's, that is actually very rare. So there are very few of those genetic changes that are so strong that they are directly linked to Parkinson's. And if you have that gene, you have a very high chance of getting Parkinson's. More commonly, though, are those genes that increase risk, but they don't cause it in all cases. And those are the ones that happen in about 15% of people with Parkinson's. And then you can have a code in many genes that alone or in combination either affect the risk of Parkinson's or how the disease expresses itself. So you sort of add up the contribution of those tens of genes, sometimes more, and we can get a risk score of your genetic contributions, of the genetic contributions. And even though there's only about 5% of cases of Parkinson's where there's a single gene causing the disease, and about 15% of people with Parkinson's who have a stronger genetic contribution. In fact, our genes influence every aspect of the disease in some way. So we talked about how genes can influence the risk of Parkinson's, but they may also influence how the symptoms happen, how they respond to medication, how their disease is going to change over time. And in addition to all that, how genes affect our body, also environmental factors, which contribute to Parkinson's, can interact with our genes. If I have certain genes which make me more or less susceptible or more or less likely to respond to factors in my environment that modify my disease. So as genes linked to Parkinson's are discovered, they've allowed us to identify many proteins that cause or contribute to Parkinson's. And I'm going to give you 3 examples here. Alpha-synuclein, LRRK2, and GBA. And these are just 3 of, as I said, tens of genes directly linked to Parkinson's. Now, the first one I'm going to tell you about is alpha-synuclein. Alpha-synuclein is a protein found throughout our brain and our body. It's a normal protein found everywhere within us. And we don't really know what it does, but we do know that it works to allow cells to communicate with each other at a location called the synapse, which occurs between 2 brain cells. And the reason alpha-synuclein's gotten a lot of attention lately is we now have a way to measure whether someone carries an abnormal alpha-synuclein protein. So there's a test for it now. And we don't need to go through the whole history, but I'm just going to be going back to this point that, we might know about certain phenomena or certain aspects of the disease for many, many years, but we really can't put our finger on the issue. And then the gene is discovered, and then just in a few years, our whole understanding changes. And this is what happened with this protein alpha-synuclein. Back in 1910, there was a pathologist looking at the brains of people with Parkinson's, and he saw these structures called Lewy bodies, these little circles. And it wasn't known what was causing these little circles, these Lewy bodies, but in 1997, the synuclein gene was linked to Parkinson's. That was actually the first genetic discovery linked to Parkinson's. And just a few years later, we were starting to able to stain for alpha-synuclein and found out that the Lewy body is full of this abnormal alpha-synuclein. And then 20 years later, a test was developed that could actually measure abnormal alpha-synuclein. So you see how the discoveries are accelerated by genetics. And so, as I said, we have alpha-synuclein normally everywhere in our body, and it is a normal protein. But what happens in Parkinson's is it starts to misfold and clump up and clogs up our cells. And leads to the accumulation in Lewy bodies. So that's what a Lewy body looks like. And so right now there are many research studies going on trying to target alpha-synuclein, first to understand more about it and how it contributes to the disease, and then to try to stop the protein from misfolding or help the body remove the protein if it accumulates. So that's just one example. The next example we'll talk about is the LRRK2 gene. The LRRK2 gene was discovered in 2004, And LRRK2 is important because it is the most common genetic contributor to Parkinson's known to date. But it's not it's a sort of a medium risk gene. Not everyone with the genetic change in the code of LRRK2 gets Parkinson's, but it's about 30%, though as someone gets older and older, that risk increases. So about 30% of people with the LRRK2 gene change get Parkinson's. What's very interesting about the LRRK2 gene is it plays a role in people even if they don't have a genetic change in the code. That protein is very relevant to Parkinson's. And individuals from certain parts of the world, people with certain ancestries, are much more likely to carry Parkinson's related changes in this gene. So if we look at this map of the world, we see that, for example, in North America, if we take all cases with Parkinson's, about 1% of people have the LRRK2 change, but in North Africa and Tunisia, or in Israel, among people who are of Ashkenazi Jewish ancestry, it is much, much more common. So this is just a good example of how we need to study people of different ancestries to learn more about Parkinson's genetics. And LRRK2, as we talked about, when you have a genetic code that changes a protein, it can cause the protein to be over or underactive. In this case, the protein's overactive. And so there are drugs being developed to try to reduce that overactivity. And these drugs could benefit not only people who carry specific genetic changes in the gene, but also all people with Parkinson's, because this enzyme, this protein, plays a role in our cells, even if we don't have the genetic code change. And going back here to look at history and how things have really been accelerated by genetic discovery, the location in our DNA where the LRRK2 gene exists, that area was first linked to Parkinson's in 2002. So we sort of knew something was going on in that area. And then the LRRK2 gene was discovered. And by 2017, therapies had been developed and tested in humans. And so 15 years really is not a long time considering how long we've known about Parkinson's and how long it takes to translate these discoveries into potential treatments. Finally, the third example of many that I'm going to give is the GBA gene. And this gene was first discovered in 1997, but it was only in the 2000s that its link to Parkinson's was first defined. And this gene change occurs in about 7% of people who have Parkinson's disease, for example, in the United States, but among certain groups, such as people who have Ashkenazi Jewish descent, it's much more common, occurring in about 20% of people. And this is a protein where when it is affected by a genetic change in the genetic code, it stops working normally and we get a buildup of other proteins that it interacts with. And so a lot of research studies are going on right now trying to investigate how to make this protein work better so that it clears up some of the abnormal proteins that accumulate. So I've gone through some of the genetic discoveries that we know about Parkinson's. How common are these gene changes? So there's a study called the PD gene study where 8,000 people in North America were studied, and 13%, these are people with Parkinson's who are seen in our clinics, and 13% had a relevant genetic change. And you see over here on the right, this pie chart, GBA variants were most common, followed by LRRK2. And here we see that synuclein gene variant was not very common. It is rare, even though we know synuclein is important in Parkinson's. So now going to why does all this matter? I've mentioned some of these, the consequences of learning about genetics, but so genes, if we can learn about genes in people with and without Parkinson's, it tells us information about what causes Parkinson's. It helps us understand why some people develop Parkinson's and others do not. It also allows us to monitor people without Parkinson's who have the genetic changes, so we can find people who might be at risk and monitor them to really learn how Parkinson's begins and evolves, the earliest stages of the disease. And it lets us understand how genes interact with our environment. But perhaps most importantly, it allows us to develop new treatments. And in this circle, you see all these colored areas represent different drugs that were being tested 2 years ago. And if we just focus in on those areas, where the purple squares are, those are all the different therapies targeting just those 3 proteins I mentioned, the discovery of which came from knowing the genetics. And just an example of how much genes are actually, genetic studies are informing development of treatments for Parkinson's. And this is not something that we know enough about now to make a reality, but in the future, knowing about the genes of each person will allow us at the individual level to do many things to help treat Parkinson's. So if we know about a person's DNA profile, in the future, we'll be able to give very specific information about how their Parkinson's might change over time, meaning their prognosis. The best treatment for that individual, we might use many different treatments according to the genetic profile. We might select medications according to whether that person's DNA is telling us they metabolize drugs a certain way or they're at risk of certain side effects or drug interactions. A person's genetic profile might influence decisions they make about their lifestyle factors and certain chemicals they may choose to expose themselves to or work very actively to avoid, and tell us, of course, the risk of Parkinson's in this person if they don't have it already. So that's what personalized medicine is. It's really using genetic factors to really help us treat an individual person. So I'm going to go back to something I mentioned earlier, which is the importance of diversity in research studies. Parkinson's affects people of all races, of all ethnicities and backgrounds. But until recently, in Parkinson's research, the majority of participants were male and identified as white and were of European ancestry. We actually had very limited information on genetic contributions to Parkinson's in people from other ancestries who are not white and who are not male. And since we inherit our genes from our ancestors, it's really important to represent people from all ancestries in Parkinson's research. And just as an example of this, if you take this map of, if you take people with Parkinson's disease from European ancestry, in this circle represents all our chromosomes, where our DNA is, and you see all these different locations. Every line represents an area in our DNA where a genetic change linked to Parkinson's has been found. But if you take people with Parkinson's who are of African ancestry, we see just a few areas in the DNA where we know there's a link to Parkinson's disease. So, but there's a study called the GP2 study, which is really aiming to address this huge gap in knowledge that we have because we haven't had representation of people from different ancestries in our research. So this program, the Global Parkinson's Program, or GP2, is aiming to understand Parkinson's genetic and more diverse samples, aiming to collect 250,000 DNA samples from across the world, and has already made huge progress in this regard. Already 100,000 people from 77 locations in the world have contributed DNA, including about a third of this sample are people from areas that were previously underrepresented. And one of the GP2 efforts that's really important is the focus on recruiting people who are of African ancestry, who identify as Black, into Parkinson's genetic research. And Dr. Disbrow and her team at LSU, where you are today, are a key part of this initiative. And the Black and African Americans Connections to Parkinson's Study, or Black PD, is the study I'm referring to. And Dr. Disbrow and her team are one of 11 sites right now recruiting people with Parkinson's and people without Parkinson's who identify as Black or African American to contribute DNA so that we can learn about genetic contributors to Parkinson's in this study. And so we need people to participate in these research studies. And if you Parkinson's or know people who have Parkinson's, or you don't have Parkinson's, but you're interested in being involved, you can participate. It would involve you providing a DNA sample and some questionnaires and a few other assessments. So to learn more, I think the next speaker, Maddie's going to be telling you a little more about what's going on in your area, but there's also this phone call you can, this phone number you can call. There's a QR code, and I'm sure there are going to be some materials at your location where you can learn more about this. So with that, I'll stop. I think there's time for questions if there are any.
Thanks, Lana. That was great. I have a question. Can you tell us a little bit about what we've learned so far from Black PD, from the results?
So right now, as I said, over 1,000 samples have been collected and analyzed. And one of the discoveries that Black PD has made is that many of those genetic changes that I showed you in, for example, in the PD gene study, which included predominantly people who are of European ancestry, 13% of people carried the genetic changes we know of. In Black PD, that number is very small. It's less than 5%, which really tells us we do not know the genetic contributors to Parkinson's in people who identify as Black or African American. So now there's a lot of research and discovery to find those changes. And in fact, one such change was identified, a change in the genetic code specific to people who are of African ancestry was identified in GP2 study by a group of researchers in Nigeria. And then the Black PD study sample was used to also investigate that gene.
Thank you. Do we have any other questions about genetics? Yes.
Thank you. I hear that we don't know much about genetics and how they're linked to Parkinson's in African American communities. But can we make a leap from that to guess that family history plays less of a role, more of a role, or we don't know in Parkinson's showing up in Black people?
I think right now we don't know. In our study, in the Black PD study, at least 15% of our participants have a family history of Parkinson's. We certainly do see familial Parkinson's in the Black and African American community. It's just that we don't know the genetic contributor. So one of our priorities will be to study cases that have a family history, and hopefully one day we'll even be able to conduct studies among people, among families who have Parkinson's in the Black community to understand more the genetic contributors.
I've been pushing for that one.
And I guess I'm the different. Have had the genetic testing and do not have the genes, but they call it sporadic. I am a product of Agent Orange from the Vietnam era, and so I was tested because of my sons to see if genetics was going to be a problem for them, and with what we know now, it is not going to be. However, the Agent Orange has affected not only the fact that I have Parkinson's, but a number of other genes. This MGUS is now been added to Agent Orange, the Agent Orange registry, and a number of issues because of the defoliant that was used at that time.
Yeah, so you raise a really important topic, which is that even among people such as yourself who have sporadic Parkinson's, meaning no genetic contributors that are causative of the disease, there are environmental factors that contribute to Parkinson's, such as Agent Orange, which is a pesticide. And this brings us to the important topic that even when a person doesn't carry genetic factors that cause Parkinson's, they might increase, your genetic factors might increase or decrease your susceptibility, how sensitive you are to pesticides. And, going beyond exposure during military service, in the United States, pesticides are used on our food supply and many other areas in the United States and elsewhere. And so this is where people who might have genetic factors increasing risk of Parkinson's may want to know about pesticide exposure and who may be more or less likely to be sensitive to pesticides. So these are very important topics, and in the GP2 study and in the Black and African American Connections to Parkinson's study, we are collecting information about exposure to pesticides, to Agent Orange and other chemicals, trying to understand the relationship with genetics and with Parkinson's.
Yes, ma'am.
Thank you for the presentation, awesome. I have two questions. In the study, have y'all captured any data to say what the barriers are with African Americans not being tested? And with the study, how are you capturing that data?
It is my impression that the Black and African American community are very interested and eager to participate in our research study. I think the lack of representation of the community in prior studies was largely a fault of researchers not bringing studies to people outside of certain areas and centers in the United States. So that's investigators like Dr. Disbrow who are involved and engaged and bringing this study to areas that were not previously represented in research is a big component. But of course, just as most people, when they hear about research, have questions about privacy, have questions about how do I get to the research center. And so some of the barriers to research participation are access to the center, time to get there, and then concerns about privacy and security. So we've been working to try to identify some concerns that people might have about research participation and address them to the best of our ability by, for example, providing transportation or trying to minimize the burden of the study on people by trying to make the study visit quick and such factors.
Thank you.
And we actually have so we're a site for Black PD, but we also are doing a study on trying to break down some of those barriers. So I'm really looking forward to talking with you about that. And if anyone has any suggestions about how we might better reach folks, we're working on transportation, and we're really, this is a hot area right now that we're really investing in trying to solve some of these problems.
Thank you. My question has to do with the agriculture industry. I work with some farmers, and I have asked them to go back as far as 3 or 4 generations that they could tell whether or not something like paraquat, which I keep reading a lot about, is also a contributor to Parkinson's. So how would you suggest we really kind of clarify that with the farmers? Because I know a lot of them certainly don't use paraquat anymore, but they use other insecticides. So is there an inclusive list somewhere that we have access to that could help the farmers make sure they're not using that product for insecticides? And then I have a second question.
And this is really a very important topic. There really is a need to get those lists of products out there. It's a challenging thing to do because the research on the specific chemicals is not always available. But I think there's some really good research right now to show that even wearing PPE, protective equipment, gloves, and masks is really, really important. And so at the national level, there's certainly a lot of policy advocates trying to ensure that those chemicals that we know for sure are high risk, not just for Parkinson's, but for general health, are removed from the market, taking the burden off the farmers to try to figure out what's in these chemicals. So hopefully that will happen. But in the meantime, any I think that people in the agriculture industry would really benefit from education about using PPE, protective equipment. Even simple gloves and masks have been shown to reduce the risk substantially.
So I'll follow up on what you just said. So are there programs, or are we talking about programs that perhaps your state agriculture commissions or your USDA branches of the federal government can do to help the ranchers provide this information to them? Is there something that's being done about that?
That's a really important question. I have to admit, I don't know the specifics of programs that are occurring, but I do know there's a lot of advocacy. In fact, advocacy being led by the Michael J. Fox Foundation specifically around this issue. But to speak to specific programs with the USDA and farmers, I don't have that information.
Okay, my original second question is this. You mentioned with some of the research that's going on in the DNA and the genetics of the Black and African American communities. So what are some of the things that Michael J. Fox is doing to ensure that they reach that community and begin engaging them real time in what it is that we need to do?
Yes, this is an important question that inspired this study, the Black PD and the GP2 study. And I think Dr. Disbrow and her team are going to be telling you more about some of those initiatives, whether, one of the key things is bringing the research studies to the communities. Up until Dr. Disbrow's team were involved in the research, there was just a huge desert geographically of people who did not have Parkinson's specialists near them to even bring them these research studies. Going beyond that is in terms of, using media where possible across different types of media, newspapers, radio ads, and then for people who are on the internet, social media, to try to deliver the information that these are studies going on in your area, that there are movement disorders neurologists in your area who can see you, diagnose you, increasing awareness of Parkinson's disease. So these are the main strategies. So to summarize, is to bring the research and the resources to the community geographically, and then to use various aspects of media to educate about Parkinson's, and then subsequently to educate and engage about research in Parkinson's.
Yeah, we're definitely focusing on raising awareness and understanding of what the disease is, that there's medication that can help. We've tried billboards and bus ads, so we're doing outreach to raise awareness. We're working with, we're starting to branch out to primary care providers because they're the first line of interaction for all of us, and trying to empower them to better identify Parkinson's disease. It's a little tricky. We've learned a lot about the presentation, but it can be quite different in different people. And so these are things that inspired us to have this meeting today, and that we've had some other meetings with the Michael J. Fox folks, and we are open to any suggestions that you have, because good ideas come from all over the place, and we need to fix this. Yeah. Anybody else? All right. Thank you, Dr. Chahine. That was wonderful.
You're welcome. Bye.
Okay, next we have McCall. She is a licensed clinical social worker. She's just recently graduated from Grambling. Give them a shout out. And she's part of our team. She's a care navigator, and she's going to tell us what that means. And she's also going to give us information about how, if you have Parkinson's disease, we can help you get genetically tested for a study. And she's going to tell us a little bit more about Black PD.
All right, good morning. Again, my name is McCall. I go by Maddie, and I do work at the Center for Brain Health with Dr. Disbrow, and today I will be sharing information on how to enhance the support for people with PD through clinical resources, care navigation, and research opportunities as well. All right, so first we're going to talk about Parkinson's resources. So these are two new movement disorder specialists, Dr. Natalie Changa and Dr. Harleen Carr, and they do have a clinic here at Ochsner LSU Health. They are experts at managing PD medication, and we're also working with them on a new patient clinic, and they are accepting new patients, and they are here, and listed above is their clinic number. And if you don't have to write it down, if you can't write it down, we do have that information down at our table. And so if you do have trouble getting in contact with them, you can also call us, and our information is down at the table as well, and we can try to get you connected with them. Alrighty, so at the new patient clinic, we have care navigation, and so we're talking about a care navigator, which I am a care navigator, and also April Strickland is a care navigator at the Center for Brain Health. And we're helping provide care navigation, as I said, and the care navigator basically ensures that both the person living with PD and their caregiver have the education, support, and the resources they need to navigate the challenges of Parkinson care. So we create a customized care plan, and what we do is basically we serve as the main point of contact, helping to coordinate the care and provide the guidance throughout the journey. And we use this care plan to talk about the values that is important, and then we address the medical and non-medical needs of individuals living with PD and their care partners as well. Alrighty, and that's what I just spoke about, the customized care plan. And then, like I stated, the value map is a tool that helps the clients identify what matters most and how PD may impact these things. And then we generate the care plan to address the medical and non-medical needs. All right, these are some examples of the medical needs that we help you address in the caregiver support, applying for financial assistance, and supporting with navigating the healthcare system. And these are some examples of the non-medical needs that we help you guys address. And it's it could be assistance with applying for disability benefits, food and housing insecurity, senior support services, those Parkinson-specific exercise programs that we spoke about earlier. And also we help with referrals as well. And we also are doing monthly follow-ups to provide ongoing support and check-ins as well. Alrighty, so when we are at the new patient clinic, we also have we evaluate how effective the program is. So we ask people to take a survey before and after the navigation, and it consists of questions about demographic, health literacy, self-efficacy, quality of life, research engagement, and mental health and social support as well. So just to let you know, all this information can be found on our website. And if you just search on Google, you can also find us as well. Just put in Center for Brain Health, LSU Health Shreveport. And if you have any questions, you can email us. And if you email us, it also comes to our, if you call us, it also comes to our email. So if we miss your call, we will get that email and we'll give you guys a call back. Alrighty, so now I'm going to talk about the research opportunities. And this is how we collect the data for the studies that we just learned about. And we have 2 projects that we are collecting genetic material for. So the first is what you just heard about, the PD generation study. And the purpose is to provide clinical genetic testing and counseling to people with PD, and it's to better help us understand PD causes and treatments. All right, and here are the inclusion and exclusion criteria for the PD generation study. The study involves providing some health information, 2 tubes of blood, and if you're interested in the study, you can learn more at our table as well, and you can even sign up if you want to as well. Okay, and this is kind of a workflow of what happens once you come in for the study. So after you provide your health information and your 2 tubes of blood, your samples will be shipped, and then once we get your genetic counseling done, if you say that you don't want any secondary health findings, there's no additional steps. Now, if you do confirm that you do want secondary health findings and they come back negative, then that's the end of the study. But if they do come back positive and you do have some health findings, you will be contacted by a genetic counselor, and they will provide additional counseling. And to sign up for that study, you can call us, and our number is listed, and then you can also sign up online as well. And if you decide, there we go. So if you decide to go through the Parkinson.org study, they will send you a kit to your home that you can do it yourself. And like I said, there's a QR code if you want, and we also have those on the cards that you can scan, and you're able to set up your own appointment as well. The next study I'm going to talk about is the Black PD, Black and African Connections to Parkinson's Disease. And the purpose of this study is to identify genetic changes linked to PD in Black and African American individuals, and is to support the development of future tests and treatments and improve understanding of PD overall. So we also have the criteria for the people with PD, and we have some inclusions and exclusion criteria. And then during the study visit, consists of doing enrollment in those informed consent forms, completion of those questionnaires. We also do a motor assessment, a smell identification test as well, and that consists of a scratch and sniff test. And then we have the MOCA test, it's a cognitive assessment. And then as I stated earlier, we do have the blood collection, that's 3 tubes, really small tubes drawn by a nurse. And you can sign up for that study, as I listed, by calling us or emailing us, or you can also sign up online, and then you can learn more about the study at blackpd.org. And that comes to my ending, so any questions?
Just clarify, is care navigation available? Who is it available for?
Care navigation is available for those that are diagnosed with Parkinson's.
They don't have to be in the new patient clinic, just anyone who would like some assistance, just give us a call and we'll be happy to help address your medical and non-medical needs.
Wait time. How long is your current wait time for assessments for new patients?
Okay, so once we get a phone call, email, or however you contact us, we make contact with you and we get started right then, just figuring out what you need help with and what's going on, basically.
To be seen by a doctor?
Oh, I thought you were saying for care navigation.
To be seen for a doctor, we would have to ask them, but it's weeks and months, not years. It's going to be reasonably fast.
Is that for just Louisiana residents?
Which part?
The access to this clinic. Do you have to have a Louisiana residents to participate in your clinic?
So to see the doctor will depend on your insurance if they let you go across the border or not. To get care navigation, we have not yet started in East Texas, but that is on our list. That is on our list. So maybe within the year we should be able to handle that.
this is a little bit of a detour, but y'all talked about the olfactory stuff being something present like 10 years before people even knew they had Parkinson's. Is there like scratch and sniff tests so people like me that are getting old could like test their olfactory?
Yes, so we use the smell identification test. It's a series of 40 scratch and sniff, and then there's a multiple choice for you to identify the smell, and then there's guidelines for what's normal and what's abnormal. Yes, ma'am.
So you mentioned referrals to support services for seniors. What type of support services do y'all typically refer to? And then you also mentioned helping qualify for benefits and kind of alluding to this gentleman. Do y'all help if they need to get connected to the VA because they were veterans, because that system can sometimes be complex? So 2 parts.
So referrals, as far as you stated about the support services, the senior care. So we reach out and we work with Healthy Aging, the Council on Aging. We work with them and try to get you connected to them. We try to make the calls, get your name and information written down, and follow up with you to see like where are you, if there's a waiting list. Like we try to follow up and keep monitoring what's going on as far as getting you connected with them.
We might refer them to the Bossier Council on Aging, for example. I'm teasing you.
Yeah.
And we also help. We're just starting to work with the VA. I've been talking with their director of their caregiver support services. It is very complicated. It is very complicated. We are just starting to try to make those connections, and we vet everything ahead of time, so it's not ready for prime time yet, but that is definitely also on the list.
I deliver meals for Meals on Wheels for the Caddo Council on Aging, and one of the things that always concerns me is the people who live by themselves, have no caregiver. I saw something where you do monthly check-ins or whatever for that. Is there some type of program? I know, like we've got the Life Alert things that various organizations have, things that where you can check in with them and you put a caregiver. Do we have like a database or something of people who need that kind of help, or do we have a group that's willing to be a their check-in person if something happens, if they fall or something like that, if they don't have anybody local?
We are starting some programs specifically for Alzheimer's and Parkinson's disease to do this sort of check-in thing. We don't have plans to do a general one, but I know that's a terrible need, and so we can talk some more about your insights there and how we might be able to help you with that and the folks with that.
Thank you for your presentation, awesome, and shout out to GSU. But I want to ask for some clarification. You mentioned early on, like doing the algorithm, like for testing, and if they wanted to do more testing in the event that more medical conditions were discovered. So what medical conditions are you referring to? Is it related to Parkinson's, or is it like comorbidities or things that they already have and being treated for? And part 2 would be, and is there a connection, or are you working with, if they have a primary care provider, so it's not like double dipping care?
The secondary health findings, I believe, is like colon cancer, and then we're talking about the 7 genes as well. Oh, okay. So these are, I know she spoke about them in the last presentation, but these are some of the, these are the 7 genes that confer PD risks. And you have the GBA, and it helps the cell clean up and recycle waste. And I'm not going to name all of them, but these are the secondary health findings. Gotcha. The primary ones.
Yes, we're testing for those, and then I think you have the slide on the second batch of genes. It's not in there. Okay, so the primary testing is for these 7 genes, and you consent to get counseling if you like. This part is a little bit complicated, and we tried to make a picture, and I'm not sure that it really helped. And after that, they'll do an analysis of several secondary health findings that are not related to Parkinson's disease. There's some other diseases. The BRCA, the breast cancer one, is the one that's popping into my head because that one's pretty common. But and you can consent to receive that information in a second session if you test positive or not. So you'll receive genetic counseling on Parkinson's risk genes and non-Parkinson's and risk genes for other diseases. Yes.
I know you're talking about, caregivers. Is your organization, is it doing anything to help our veterans and the homeless, I'm mainly speaking for homeless veterans, and the mental ill capacity that a lot of our veterans go through, but having mental illness combined with Parkinson's disease? Is there anything you guys doing along those lines?
Not yet. I think Dr. Disbrow spoke on it just a second ago, that we're trying to build that connection with the VA as far. But I mean, if we get someone that, like you stated, is in one of those conditions or all, we will try, to do what we can do to help them and reach out to all the community resources, see what we can do.
Yeah, I know you would, but I'm just saying in the community, you see a lot of veterans with Parkinson's disease, and they got a mental problem.
So we work with their existing team, and if they don't have an existing team, we try to get them an existing team. Yeah, in a perfect world, that would work great. It's very complicated. Yes, yes.
And there are a number of support groups. I know Shreveport has several. My wife and I host a Longview Parkinson support group in East Texas, and of course Tyler, where there's another movement and motion disorder specialist, neurologist. So might suggest that work with those groups as far as trying to get more information out about the program.
We do also work with the Northwest Louisiana Parkinson Resource, and I know they meet at the, Willis Knight Eye Institute. I'm not sure, I think it's the third Tuesday or second Tuesday of the month, but I can get that information. Friday, I'm sorry, not Tuesday, that third Friday. I'm getting them mixed up with another resource, Parkinson resource. But I do have the information. We do have the information about the resources that are locally. We do have that information, and we make sure that as far as like when we go and we do the new patient clinic, we have a folder that we present each patient with, and they take that folder home. They have our number. They have a magnet they can put on the fridge to call us if they need to call us. They have all those resources listed in there and recommendations as well. So we do give a book, a folder full of resources when we speak and talk to the people with Parkinson's.
These are all really good suggestions, good things to think about. I don't think I've thought about the veteran thing as much. That's a good topic. Thank you.
The area for this for the different studies and supports, and recognizing that even today we're doing virtual, is it only for Northwest Louisiana, East Texas, or is this open to like the whole state? What are we looking at?
Well, right now we're starting more in our more local area. This work that we're doing is in parallel to a program that we're doing with Alzheimer's disease, and the plan is to take both of them into East Texas and, if need be, into South Louisiana. I mean, they have a different resource structure, and we're debating about whether or not we're going to try to do that. But right now we're doing North Louisiana.
Y'all had mentioned in another presentation about like the singing with Parkinson's and the boxing, and I've heard of the dancing, and I was wondering if there were some like local programs that had some kind of like dance off or sing off where non-Parkinson's people that just care about Parkinson's people could come to, if that would be a good way to spread the word about your research studies too.
That sounds like something you could help us with. Yes, I get that.
We have Moving Day on the 25th, which is going to be the Parkinson's Foundation Walk for Parkinson's. And I know that there are several things up on Facebook about it. We have the local Shreveport-Bossier support group that meets the second and fourth Tuesday of every month. And we've got several members on our team there. We also have the Northwest Louisiana Parkinson's resource that you were talking about that has a Facebook page, so you can find those on there, or you can find them at parkinsons.org. But that is on April 25th, and we do want everybody to come out.
Excellent. Are we ready for lunch? Yes, thank you. All right, so we have plenty of time. We have about an hour and a half for lunch, and please see the vendors downstairs, and let's do a couple more T-shirts before we... I think we promised to do 6, right? Somebody was saying we needed to do 6, so let's do 6. You want to come down and pull them? Who said 6? Come on down. And you read the last 4 numbers. Yep.
Okay. All right. Lucky number 0578.
Read the name on the other side.
Patricia Bissett. Yes! How many?
6.
6? 6 more?
No, 5 more.
Oh, 5 more.
6
Okay.
plus 1 is 5.
Lucky number 0643.
Larry Ellis, maybe?
Maybe Larry Ellis.
It's Larry.
Larry something? Do we have any Larrys?
Okay.
Well, he deserves a shirt.
Yeah.
All right. We're going to go with 0582.
Yes. All right.
Yay! Okay, I lost count. I don't know what I'm at. 3 more?
3 more.
Okay. 0615. Yes!
Yay.
Okay. 0610. Yes! We need more clappage.
Yes, we do. One more.
One more, everybody.
One more before lunch.
All right. 0649. There we go. Thank you so much for this opportunity.
Thank you for suggesting it. Okay, so you pick up your shirts down at the registration table. We've got a bunch of different sizes, and we'll meet back here in about an hour and a half. Thank you.
Good afternoon, everyone. Hi. Hi. I see a lot of familiar faces in here and some new ones. So this is why I'm here. My name is Wendy Taylor. I'm an adult geriatric nurse practitioner. I'm affiliated with Willis-Knighton and LSU. I'm certified, in movement disorders. So yes, that includes Parkinson's. I specialize in the deep brain stimulation and medication management. But I am here under my other hat, which might be my favorite hat. I am the Northwest Louisiana Parkinson's Resource Coordinator. I have brought some goodies for y'all. Is my new newsletter for the next several months, and I've also brought little flyers. It's kind of a big deal. This is the first time that Shreveport will be hosting the Parkinson's Foundation Moving Day. I stole it from Baton Rouge, so we kind of need to show up, okay? It's a big deal. So if you're interested in joining our local resource meetings, we meet every third Friday at Willis-Knighton North. All this information is right here. Our next meeting will be March 20th. I'll have a rehab physician coming to speak to y'all. And I think that's about it. I love seeing this. This is a great facility. Thank you, Dr. Disbrow, for giving me 2 minutes and for hosting this. Where should I put these? Oh.
Let's hear it for Wendy. Yay. We have a table downstairs if you want to put it on the LSU table, or we can leave a couple, or why don't we just put them right on the table right out there, and then people can grab them as they go by.
So they'll be right outside of the table, guys, so make sure you get some. I want to see faces at the next meeting.
All right, so as you can see, we have Dr. Purks with us today. She's going to talk about prevention and also the environment, which is something that we've been talking a little bit about today. There's a lot of interest. She completed her medical degree at Georgetown and did a residency at the University of Rochester, and she's now doing a fellowship to become a movement disorder specialist in Gainesville, Florida. And she's done a bunch of research, so we're really lucky that she has clinical expertise and also research expertise. And she's also done some work in Zambia, which is really interesting. So without further ado, hello, can you see us? Can we hear you? Maybe not.
Can you hear me?
Yes, there we go.
Okay.
Great, okay. And I think you're in charge of your own slides.
Yes, excellent. Thank you so much for that introduction, Dr. Disbrow, and for the invitation to speak. I'm thrilled to be with all of you today. So let me just go ahead and share my screen and my slides. Are you able to see my slides or not at this moment? Okay, give me just one moment. My apologies, I'm more of a Zoom kind of gal rather than Teams, so give me just 1 second.
You work for switches back and forth between the two of them.
Yes, keeps us on our toes, right? Great. Okay. Yep. Okay, perfect. And then perfect. Can you all see the slides at this time? Oh, I'm sorry. Hold on. Okay. Change one other thing. Okay. Do you see it now? No, right? Okay. And then there's allow to share window or share screen. Just the window is okay.
This is, how about if we raffle off some more t-shirts?
I just see it sharing Safari, but it's not picking up PowerPoint.
Okay. 0591.
Okay.
Nate. Nice. How many, okay, Nate, you get to pick how many we're raffling off right now. Yeah.
Okay. So
7. Okay. Feeling bold. And you count as the first one, so that's number 1. Okay. 0636. That is Danielle
yeah, it's just one to.
Reams.
Yeah. Okay.
I think maybe at this point must be present to win. What do we think?
But now you see what's behind me. So
0630.
okay.
All right, Emily. So close. Okay, well, I'll believe it when it's blown up.
Okay.
Okay. So what do we do? We did 2. We'll do 5 after the talk.
Wonderful. Thank you, Terri. I apologize for that. Excellent. Well, thank you so much for the wonderful introduction, Dr. Disbrow. And it's an honor and privilege to be here today and to speak with all of you. Thank you for the patience with the technical difficulties. So I'm thrilled to talk about a topic that's very close and dear to my heart, the prevention of Parkinson's disease. So as Dr. Disbrow mentioned, I'm the Edmund J. Saffer Movement Disorder Fellow at the Fixed Cell Institute at University of Florida right now. And there I work caring for patients with Parkinson's disease, from making a diagnosis, managing medications, and consideration of advanced treatments for Parkinson's disease, deep brain stimulation, Botox, infusion therapies, etc. And then I'm also very engaged with clinical research about preventing Parkinson's disease and thinking about the complex interplay, as we heard earlier, with genetics and the impact of genetics and Parkinson's disease, the role of the environment, and how those work together. So without further ado, we'll talk more about the prevention of Parkinson's disease. First, I'll start with what is Parkinson's disease. So as we heard from Dr. Abbas earlier today, Parkinson's is a loss of dopamine-producing cells in the brain, and this leads to a constellation of both motor and non-motor symptoms. So for the motor symptoms, we all think of tremor, slowness, also called bradykinesia, stiffness, which can also be described as limb heaviness, balance issues that can contribute to falls. And then non-motor symptoms, we think about sleep problems, trouble falling asleep, staying asleep, in addition to sleep fragmentation, mood changes from irritability, depression, loss of motivation, anxiety, constipation, and loss of smell. So that's a phenomenon with multiple different systems and symptoms across the whole body. So what causes Parkinson's disease? We think about aging as the biggest risk factor. We talked a little bit about genetics. Importantly, we think about environmental exposures, and that's really what I look forward to diving in today with you all. And then lifestyle factors as well, and what actionable items you can do with both the environmental exposures and lifestyle factors to protect yourself as best as possible. So that begs the question, can PD be prevented? And I hope to demonstrate to you today that Parkinson's disease can be prevented if we focus on risk reduction and brain health, and that early action may delay onset. Shaking palsy, or Parkinson's disease, was first described by James Parkinson in 1817, about 60 years after the Industrial Revolution, and Parkinson's rates have continued to rise and rise today. There's about 1 million patients with Parkinson's disease in the US today. So there's a lot we can do about this, and I hope to, over my career, work to prevent Parkinson's disease, and there'll be fewer times that I'll make the diagnosis of Parkinson's disease in clinic. So exercise is the most protective factor to both decrease your risk of developing Parkinson's disease, but also to decrease the progression of Parkinson's disease. There's a lot of fascinating studies right now, like the SPARK-3 clinical trial, among others, looking at comparing moderate intensity exercise and high intensity exercise and the impact that has on motor symptoms of Parkinson's disease. And we think the mechanism is related to improving brain plasticity, supporting dopamine function, and reducing inflammation. So I'm sure you've heard a lot about exercise so far today, and there'll be more discussion of exercise later today. But if you can take just one thing away from my talk today, it is that exercise is critical for brain health and critical for both preventing Parkinson's disease and changing the course and decreasing progression. A healthy diet is also critically important. A Mediterranean diet is best as it reduces inflammation and oxidative stress. Sleep and brain health, so maintaining a regular sleep cycle, sleeping in a dark, quiet sleeping environment, avoiding screens before bedtime, and managing vascular risk factors is so important as well. So controlling blood pressure, diabetes, cholesterol, avoiding smoking, and heart health supports brain health. So really diving into what those environmental risk factors are. So it's important to think about the air we breathe, the water we drink and consume, the chemicals we're exposed to, our occupation, and then some differences between rural versus urban exposures. So thinking about chemicals, there's 3 environmental toxins that may be fueling its rise of Parkinson's disease. So certain pesticides, paraquat, for example, is associated with an 150% increased risk of Parkinson's disease, and its use has doubled recently. Prenatal chlorpyrifos exposure is associated with reduced IQ, brain abnormalities, and childhood tremors. And then there's TCE, trichloroethylene, and perchloroethylene, PCE. Those are both solvents and basically molecules formed of hydrogens and carbons. And TCE is associated with a 500% increased risk of Parkinson's disease, 500%. And then PCE is widely used in dry cleaning. Additionally, I mentioned air exposure. So PD is the 6th leading preventable cause of death, and 40% of patients breathe in unhealthy air in the U.S. So I'll talk a little bit more about that. And this slide is used courtesy of Dr. Ray Dorsey, who I had the pleasure of working with and who's mentored me from my time at University of Rochester, and then Dr. Oken, where I'm currently doing my fellowship with him at UF. So a little bit more about the pesticides and herbicides. So we know it's linked to an increased PD risk. There's an agricultural exposure, and there is some evidence that shows when it's exposed in agricultural settings, it may damage dopaminergic producing cells. So things we think about is how can we reduce this risk by wearing, there's been studies by Dr. Tanner and Dr. Goldman at UCSF that shows in wearing protective equipment, gloves, mask, we can reduce your risk of Parkinson's disease. Next, I want to talk about industrial chemicals and solvents. So as I mentioned, TCE, it's also, we should think about heavy metals, including manganese, and it's often related to occupational exposure. So I'll dive into that a little bit more. And there has been evidence to show that hobbyist exposure to TCE has been linked to a 500% increased risk of developing Parkinson's disease. So what do I really mean by that hobbyist exposure, and what chemicals in our basements or pantries or garages and laundry rooms should we be worried about? So this slide looks at, maybe I can slide this over. The historical use of TCE. It's been in commercial and consumer products. It's been used in industry, and even in the past, it was used in medicine. So I've highlighted the ones that this is based on a recent publication in 2023, and as of that time, TCE was currently still being used in some of these areas. So we've gotten rid of TCE in medicine, previously used anesthetic to put patients to sleep during surgery, surgical disinfectant, and then even treatment and pharmaceutical manufacturing. But still, it could be found in paint removers, stain removers, air and fridge coolant, and then some dry cleaning machinery. So it's important to look on your household items, what's in the product, and then sometimes it says, it lists a few chemicals, and then it says, and 99% other chemicals. So you can ask further questions about with the company you're buying the product from, of what exactly is in the product you're using. This is also a nice summary of occupations that are at risk for TCE exposure. So painters, yeah, I won't go through all of it, but the big thing that I want to highlight is how important it is if you work in these industries to really think about what protective equipment is needed and to wear and use that protective equipment, because that does decrease your risk. And taking the time to wear the protective equipment is really essential for your health. This overviews U.S. cities that release the most TCE into the air. We'll see Westlake, Louisiana here as well. I looked it up. It's, I think, about 3 or so hours away from you all in Shreveport to keep in mind. So now I'm going to talk a little bit more about possible ways of TCE exposure. So we talked about direct contact by working through it, either hobbyist, using cleaning products, if you're doing work on your car, hobbyist as a mechanic, but then, or with your occupation, but then, TCE can go into the air, and then, it can come down in rain and contaminate the soil. It can contaminate groundwater plumes and the water in the surrounding areas. And then it can also then get into buildings via vapor intrusion. So I think the big aspect that's critical is to know where these Superfund sites are. And the good news is I looked it up. Shreveport has no TCE Superfund sites. The closest hazard site in your area doesn't have TCE. Is in Bossier City, Louisiana. That's just across the river from Shreveport. And this site has significant soil and groundwater contamination that they are cleaning up. And then there's a HM landfill that's a removal only site. So I think information is power here, and just being informed is critical. Other steps that you can impact with air pollution, we should think about how much fine particulate matter. So traffic can be really related to pollution. I have to admit, I haven't had the pleasure and the opportunity to visit Shreveport, Louisiana yet. I've been to New Orleans, but anytime that you're sitting in traffic, you could consider changing your car to the recirculation air button, if that is an option, because then you're decreasing the risk of breathing in the air around you. But hopefully you don't sit in too much traffic in your routines. And the association with air pollution is that it may increase brain inflammation. Additionally, we should speak about well water and rural living. So there has been some evidence to show that there's been possible pesticide contamination. This evidence is mixed, but I think it's important that we're aware about it. And if you do use well water, that you test the well water regularly and you're aware of what's in the well water. I did care for some families during my residency in Rochester that were exposed to well water, and their children developed young onset Parkinson's disease, unfortunately, and they had a genetic risk factor, but it might have been an interplay of that genetic risk factor with a gene mutation in addition to possible exposure to well water or other aspects. So as I've mentioned, reducing your environmental risk is the best steps that you can take. So I recommend you wash your fruits and vegetables over running water at least for 10 seconds. That's how the EPA and other groups review fruits and vegetables. They test contaminants after washing them in water for at least 10 seconds. It's the environmental working group has a great website that's free where you can go on, type in your zip code. It will show you what water you're connected with, and then for your specific water, what exposures you might have, what small traces of different chemicals or metals you might be getting, and then consider a water filter specific to whatever your exposure is. So me personally, living in Florida, we have a water filter on our fridge at home, and that's what we use. And then definitely consider water filters if you're on well water. Using the protective equipment, as I mentioned, masks, gloves, and then I already talked about recirculating air in your car. So it's important to recognize early symptoms of Parkinson's disease. These can often predate motor symptoms by decades. So that loss of smell, constipation, sleep behavior disorder, depression or anxiety, and any of these individually could be something else, but especially if you start seeing a constellation coming together. So my key take-home messages are that Parkinson's has multiple causes. There is evidence to show that the environment plays a role. Exercise is strongly protective, 150 minutes at least a week. It doesn't matter what type of exercise it is. It could be dance, it could be yoga, it could be Tai Chi, it could be walking, water aerobics. It's just important that you enjoy doing it. Because if you enjoy doing it and it's part of your routine, you'll keep doing it. And those big strides occur from multiple days and months and years of those positive habits. And maybe you don't even like the exercise that much, but you love the community that you're doing the exercise with, and you have a great friend or loved one or family member that holds you accountable. So when you build that community, that goes a really long way. And then that healthy lifestyle supports brain health. Early symptoms and a constellation of symptoms should not be ignored. So I want to leave you with this call to action. So I've mentioned Dr. Ray Dorsey and Dr. Michael Oken. I want to thank them for their excellent book, The Parkinson's Plan. This visualization is from that book. So here they present 25 actions for individuals to reduce their risk of Parkinson's. And all these steps are also helpful if you have a diagnosis of Parkinson's also. So it's especially important for those with a family history of the disease, those at genetic risk or have been exposed to toxic chemicals, either in the military or from prior work exposures, etc. So some of the things they highlight are thinking about the environment that you're in with pesticides if you like to golf, for example, advocating for your kids at school to have less pesticides sprayed on local schoolyards and sports fields. If you do a lot of dry cleaning, asking about what chemicals are used and trying not to either dry clean less or pick a place that doesn't have PCE. They've shown that if you live above a dry cleaner and are more closely exposed to those chemicals, you do have a higher risk of Parkinson's disease. So ask about if the dry cleaning area is just a storefront or if the cleaning is done on site. Thinking about some organic produce, organic wine. There's something protective about caffeine. I think we're still trying to understand the mechanism. And the next slide goes into it even a little bit more. I mentioned washing your produce, even your organic ones, adopting the Mediterranean diet, and then looking at the proximity between your grocery store and a dry cleaner. So, many dry cleaners, they found that in prior studies, if a dry cleaner was within a mile of your grocery store, there was some suggestion of higher rates of Parkinson's disease. And actually, Germany has taken upon that among itself to prohibit supermarkets supermarkets, excuse me, from being located close to dry cleaners. So if you have any option to look at those distances, that would be helpful. So the full list of 25 can be found in their book, The Parkinson's Plan, A New Path to Prevention and Treatment. That can be found in a lot of different resources and ways, and all the proceeds from their book go to preventing Parkinson's and Parkinson's foundations. So I'll leave that with, it's an honor to talk to you all today on this important topic. Parkinson's greatly impacts the lives of our patients and families. And I would love to see in my lifetime a world where we prevent Parkinson's disease, and we need to have action on both an individual, society, a community level, and we hope a stronger policy level to make some of these global changes for the US to make us all healthier and safe. So I'll take any questions. Thank you, if we have time.
Thank you. That was terrific. I have one question that's probably not specifically for you, but asking if there are any opportunities for people who are Hispanic to be tested for Parkinson's genes. And right now we are doing testing of anyone of any race who has been diagnosed with Parkinson's, but we aren't testing people who don't have a diagnosis. Naomi, I'm looking at Naomi. Do you know? Yeah, for genetic testing for people without a diagnosis. Yeah, we don't have any research. Can they get their doctor to test them?
So to confirm, are you asking pre-symptomatic?
Yeah, so do you know that? Yeah, pre-symptomatically, can your doctor test for Parkinson's, maybe the 7 genes that we're doing for PD generation or something like that?
Yeah, so I believe PD gene is hoping to be able to expand to more pre-symptomatic carriers, and then to do some further family dynamics. So, you know, if say 3 family members are involved in have Parkinson's disease and are involved in PD generation, but none of the 7 most common genes come back as being positive. I know the Parkinson's Foundation is trying to follow up with those families and possibly doing a larger gene study, so like a whole genome sequence, where they basically look at the whole gene and then try and compare with those 3 family members if there's a new gene that we aren't aware about yet. And then that's exploratory to try and find more information about those genetic variants that may be related to Parkinson's disease we just don't know about yet. From a pre-symptomatic standpoint, I think that they were also interested in including those patients at a later date, but I'm not aware of a current study that or a way to undergo genetic testing at this time.
So as you're
It's a great question, though.
Yeah, so with your clinician hat on, there's not an easy pathway to getting genetically tested as a patient who's concerned about risk. Is that correct?
Yeah, that at this time, I'm hopeful that, you know, as more personalized medicine comes into the clinic, and you know, neurology is using genetics and genetic counselors much more often than previously. So, you know, as costs come down, I'm hoping in the next few years, and within the research community, more options may be available. But right now, I'm not aware of any. It's a really good question, though.
Thank you. Okay, we got another one here.
I was just going to suggest to add landscape architects to your list, and of like vulnerable populations. And then I was wondering if you have like a family member that loves to garden, like should they be wearing, because my husband's pretty stubborn, so do I have to say, you have to wear PPE, or is that like not that much of a help?
Yeah, that's a really good question. I think it would be very helpful to use gardening gloves. Doing a little bit more, research or reading about what soil or exposures are in your area would be helpful. The environmental working group, as I mentioned, has a lot of great free online information. So you can type in a little bit more about, your address and exactly where you are. It also partially depends on, how close you are to farms, and then, what farms and what crops they're using, because different crops typically get sprayed with, different pesticides with different risks. And then there are added questions about wind patterns, because the wind patterns then actually can blow the pesticides in different directions. And then how that impacts your groundwater and your water system. There's something called aquifers, and then there's a lot of brilliant people researching based on different age of aquifers what the exposure risk is. So I know that's a lot of information. And is maybe not quite so specific for your loved one. Did you say it was your husband that loves to garden? But I would say if he's able to wear a little bit more gloves, that would be helpful.
Thank you. Okay, here we have another question.
But there's just so much we don't know about this, and it's really hard to do a large research study, because there's a lot of different variables that we have to control for, and environmental funding is sometimes minimal. So we have to do retrospective and other different types of studies, but we're working on it, and we hope to have more answers and more definitive answers soon.
Hi, excuse me. You mentioned trichloroethane. Is there any difference between trichloroethane and trichloromethane? Because while I was in the Air Force, we used to use trichloromethane to clean oxygen parts. And I just wanted to know, were they associated with each other?
That's a wonderful question, and thank you so much for that question. I think what I heard is you were asking about what's the difference in risk with trichloroethylene or TCE or trichloromethylene. Did I hear that correctly?
Yes.
Yeah. All the studies I'm aware of are with trichloroethylene or TCE. So I'm not specifically aware of the impact with trichloromethylene. With that said, I don't know if I would go so far to say that it's safe. I know the paraquat space a little bit more. So paraquat is one of the common pesticides sprayed on crops. And I know, for example, paraquat is outlawed in Peru, I believe. A lot of our fruits and vegetables will come from Peru and other areas of South America up to the US. But there's lots of areas in Peru that use diquat instead of paraquat. So, it's 2 carbon compounds rather than 4. I think it's a really complex question, because if we just add a few other, say we were to just ban TCE, and I know they've tried to take great action. EPA has tried to ban it. I think it officially got approved that they were going to ban it in the U.S. in 2024, and then based on some other, political red tape and other aspects, they're still in the process of fully making that change. But say you ban paraquat, maybe there's just a lot more dicot use. And there's lots of wonderful toxicologists, and we engage them often in these conversations. But sometimes it's hard to keep up with the studies to show about the different compounds. So I think the most interesting aspect on this point is in Europe, you have to prove that a chemical is safe before it gets used and before it's used in the community. Whereas in the US, you have to prove that it's unsafe before a law is created and it's taken off the market. So one radical, I think, excellent solution would be that you have to prove it's safe before it's used. That's obviously a big shift and dynamic shift, and maybe to some extent it goes a little bit against America as being an independent, free nation where any action can be taken, but at what risk and what risk to your health. So all that to say that I would feel most comfortable with chemicals that and substances that we know are safe. And I'll do a little bit more research about what I can find about trimethylene and get it to you via Dr. Disbrow.
Thank you. That sounds great.
So I was going to ask
And
more. Go ahead.
Sorry, the last thing I'll just say on that point briefly is I think if we were to make a large policy change to ban paraquat, for example, it would be very prudent to have an action plan about a safe alternative that our farmers could use to not leave that industry in a lurch.
I was going to ask about the testing of the soil. Is it just a soil sample, or do you need to say, I specifically want this soil tested for whatever?
Yeah, that's a wonderful question. And, as I've talked to a lot of my patients in clinic about some of these environmental exposures, whether they're, a police officer and had all their uniforms dry cleaned, or, they were exposed to a military base, or they had Agent Orange in Vietnam or whatnot, a lot of them will come and say, can I test, do like a blood test or a urine test to look at past exposures? So part of the issue is typically the exposure happens decades before the onset of symptoms and before the onset of motor symptoms. So there's no specific test as a doctor I can order in a lab or urine to look at what your future risks may be, or current levels. For your specific question about how do I look at my soil, how would I test my soil? That's a really excellent question. I have to admit, it's a little outside my scope of knowledge. I would have to, confirm with the toxicologist about how to definitively do that, even where to send it, and there might be further specifics about kind of how deep in the soil you'd have to go, and other aspects. So for these research projects, it's critical to have a extensive team with a lot of expertise across toxicology, and then the clinical aspect, patient facing with symptoms, and then the big data analysis, etc.
Thank you. We have another one.
Dr. Disbrow's book is very eye-opening, and I have a copy of it, and if anybody would like to look at it, please feel free.
Okay, but I didn't write that. I mean, it's a good book, but just to clarify, it's Dr. Dorsey and Dr. Okuna. The book is called The Parkinson's Plan.
Yes.
All right. Thank you so much. This was very informative. We really appreciate you sharing your knowledge with us.
Thank you all so much. Have a beautiful rest of your day, and I hope I've gave you much to think about didn't instill too much fear, because the future is very bright, and there's a lot of brilliant people working on solving these problems. Thank you.
Thank you. Our next speaker, so we've been taking a break every 2 speakers. We're going to do, we're powering through the 3, but they're all, they've all been good, but these are all really good. So next we're going to hear from Dr. Fausto, and I have notes on her background because she's very accomplished. She is the Associate Director of the Aging and Brain Health Alliance at Rutgers University in Newark, New Jersey. So she came from the snowy area to the nice weather that we're having. And she's a cognitive gerontologist and a neuroscientist. And she's going to talk to us, she studies healthy aging, and she's going to talk to us today about sleep.
Thank you, everyone, and thank you, Dr. Disbrow, for the invitation to speak here. I will talk about the power of sleep, unlocking better health, which is very important because we want to maintain our health throughout our life course. So I want to start off with a fun fact. We humans actually willingly stay up later than we need to, and we're not getting enough sleep in general. And I'll go through some sources that show that we're not achieving the recommended hours of sleep, and that's across the life course as well. And we're also delaying sleep with different distractions in our lives, some of which are outside of our control, and some things that are within our control. I know that many of you in the audience may have experience with caregiving, for example, and I know that Dr. Pease will have a nice talk about that later. But these are issues that do plague our entire human health lifespan. And I just want to make sure that you guys all know that I see you. I know that it's not an easy problem to solve. And I'm just trying to find ways that we can detect these changes early and then prevent Alzheimer's disease and everyday function declines over their life course. So we spend about 1/3 of our lives sleeping. That's a big time of our lives. We need to make sure that we're making that this part of our lives is optimal. And so as you can see from the American Time Use Survey, we're spending 1/3 of our lives sleeping, but then we have another smattering of things like working and work-related activities. I think we spend about an accumulated 10 years of working, and that's, across those 40-hour work weeks. Without the sleep, we spend about 10 years of our lives working. Watching television, that's a pretty big bubble, a big proportion of what we do. And again, that might be lumped into some of the things that we might be doing on the phone and YouTube and texting our friends. This might be a little bit outdated, in fact, because we should be also adding some smartphone usage to our watching TV. And oftentimes, some people are doing that simultaneously, but we won't get into that. Then we also have household activities, eating and drinking, and then other things like, look how low it is with the sports. Didn't we just hear a bunch of talks where, very fantastic talks talking about the importance of exercise, physical activity, physical fitness, all of which are related? Guess what? We're not getting enough of that either. So I'll touch upon those topics as well briefly. So this is a rhetorical question. I don't need to hear any answers, but how did you sleep last night? Just pause on that. Okay? And just think about whether or not you feel truly rested, because that can, give you a good foundation for your day or not. If you're already starting off on a rocky seas with your sleep, you're not going to wake up feeling refreshed. And I'll tell you more about what that looks like. Okay, sleep is complex. It is a state of altered consciousness. You're not totally unconscious. You're awake-ish, right? Your brain is somewhat doing some things, and I'll show you what those things are. In sleep stage N1, that's like light sleep. That's the lightest sleep. you're easily kind of jostled awake, kind of like that falling sensation when you wake yourself up. That was probably still in that light sleep, the lightest sleep. Then you transition into something called N2. These are all non-rapid eye movement sleep stages. So N2 is a slightly deeper sleep, but it's still considered a light sleep stage. And then we have N3 sleep. That's the non-REM stage 3, and that's called the deep sleep, also known as slow wave sleep. And so this stage is believed to be the biggest piece of preventing Alzheimer's disease for sleep, and also protecting brain health in general, and for recharging your body. So my research focuses on this particular sleep stage. And not to go too into the research, but we're seeing in this longitudinal cohort of older African Americans that I co-run with the director, is good sleep may mitigate genetic risk for Alzheimer's disease. So if someone is cognitively healthy, but they have elevated risk for genetic risk for Alzheimer's disease, that is, by the way, specific to African Americans. And I can tell you more about this particular gene later on. But if someone has that high-risk genotype, if they get good quality sleep, you can mitigate that genetic risk. And so a big part of my research is trying to not just give this one-size-fits-all approach to, oh, sleep well. No, there's also some nuances with who might benefit the most from these interventions. And then I want to talk about REM sleep briefly, rapid eye movement sleep, also the dreaming sleep. And we spend about 2 hours a night dreaming, and that's considered mostly in that REM stage of sleep. But as you can see in that graph, roughly every 90 minutes, we're cycling through N1, N2, N3, REM, and then going back, and it's not necessarily cyclical. You might go from REM and then N2, then N3, and then back to REM. So, but overall, if you have a healthy sleep cycle, you're going to have about 6 to 8 cycles per night. And then one more issue here that I want to mention is during rapid eye movement sleep, that's actually important for memory consolidation and learning. So if you are, reaching that REM stage of sleep, that's a good thing. Another thing that I want to mention there are certain micro-architectural features of sleep. I know that's a crazy word, but basically it's saying there are specific brain waves that you see in your brain when you're sleeping. And there's a particular brain wave feature called sleep spindles. Sleep spindles are commonly seen in that N2 stage of sleep, the one that you're basically spending about 50% of the sleep cycle in. If you're seeing more of these high-frequency burst sleep spindles in that stage of sleep, that's a good thing. You're consolidating those memories. And of course, you're not able to see those brain waves unless you go to a sleep specialist and undergo what's called a polysomnography exam, where you sleep overnight. And my research takes that polysomnography to the community. We have an ambulatory device, a device that we take to the participants and our patients. They wear it at home in their naturalistic environment. So we're actually tracking their sleep as they are living in the community, not just in a sterile hospital, clinic, laboratory environment. So let's talk more about this high-quality sleep. And sorry, the words are cut off a little bit on this screen. But high-quality sleep in that deep sleep stage helps clear out toxins in the brain. Those toxins you might have heard of are those beta amyloid plaques. And a lot of research has focused on the accumulation of these amyloid plaques in the brain. And just because someone accumulates these plaques in the brain doesn't necessarily mean that they will decline to a neurodegenerative state. Right now, I probably have plaques in my brain as someone who is aging continuously. We all might have a level of plaque in the brain, but there is a level where it does become detrimental to brain health and turns into a neuropathological disorder. During deep sleep, though, and when it's a healthy, good deep sleep, the spaces between those brain cells open up, allowing that toxic waste to clear out into the cerebral spinal fluid. So that's why it's so important for us to flush out those toxins. But on the other hand, as I kind of alluded to, as we age, we're getting less sleep, we're getting less quality sleep, we have caregiving responsibilities, we're transitioning from work to semi-retired to retired. Some of us are still working part-time, things like that. So those kinds of life experiences also contribute to sleep deprivation. So I want to hammer this home. Obviously, sleep changes as we age. When you're a baby, you probably need 16 to 18 hours of sleep a night, and that makes sense. You're developing, you're growing at a faster rate than when you're a teenager or when you're a young adult. But then your internal clock speeds up. Your biological clock is like, okay, we're developing, we need less sleep. And so by the time you're a teenager, you about need 8 to 10 hours of sleep. But then as an adult, we need about 7 to 8 hours or more of sleep by the time we're in adulthood and then even into older adulthood. So you might notice, even with some of the sleep disorders that we talked about earlier, like obstructive sleep apnea, restless leg syndrome, things like that, people are going to have these frequent awakenings, and that is fragmented sleep, which is not healthy. And we want to make sure that that's as continuous as possible. So we'll go on with the adulthood and older adulthood sleeping. How do we maintain healthy habits for sleep? We've touched upon this before, but a mix of different types of physical activity. So the US Physical Activity Guidelines in 2008, and then they were updated more recently by one of our colleagues in 2018, we need 150 minutes of moderate to vigorous activity a week, and that equates to about maybe 3 days where you're exercising for maybe almost an hour, and then maybe other 2 days you can do some stretching, yoga. That being said, I know that honestly, whenever I see this, I'm like, not a lot of people have time given different constraints, their lifestyle, their caregiving, everything. So it's not lost upon me to mention that there is also another study. There was a study, a meta-analytic study, where they combined different studies across the globe. And as you can imagine, different types of studies are varied. There's a lot of heterogeneity, if you will. But they're able to statistically combine them to see what's the overall effect of just a little bit of exercise. And what they did was 5 minutes of exercise a day. What's the effect of 5 minutes of exercise a day on mortality risk, their death, mortality risk over your, I believe they did a 10-year follow-up. Even if you only exercise 5 minutes a day, you are decreasing your mortality risk over that 10-year life course or that 10-year span by 6%. So it does sound small, but it makes a big difference when you're thinking about the decades that we're living. So any little bit counts. I want to mention this as well. This picture is one of our Motown classes. So I designed this exercise trial where we do Zumba to Motown. Again, I work in an older African American cohort, and a lot of the music that they grew up with and my mom grew up with, so I love Motown, we developed this exercise program where we are exercising to the Spanish versions of these Motown songs from The Temptations and Diana Ross and Marvin Gaye. So it's really exciting to see just this cultural piece that we infused into this, not just doing treadmill walking, which, to be honest, I believe is boring, but maybe other people find interesting. In our community where we work, we want to make sure that this is also culturally appealing, not just efficacious. So a few things about regular physical activity and the benefits of those types of programs. We're able to regulate our body temperature better when we exercise regularly. Obviously, there's great mood benefits. We talked about brain-derived neurotrophic factor, which I kind of see, if we think of an analogy, it's like the fertilizer for our brains. So when you're increasing that protein in your brain through exercise and regular physical activity, we're increasing the levels of that BDNF, that protein that's like a fertilizer for our neurons to continue staying stable throughout our life course. And then finally, we also touched upon in another talk where our inflammation in our body is also being reduced through this exercise and regular physical activity. And now we want to move on to diet, because there is also this bi-directional relationship between diet and sleep. We touched upon the Mediterranean diet, so leafy greens, access to legumes, you know, high fruits and vegetables, high in antioxidants, fish oils and omega-3s. Those are all good for the brain. Those are brain healthy. We do try to say limit these kinds of things like butter and cheese. I recognize they do taste good, so I always say in moderation is fine, but overall we want to strive for more of this less processed food that's heavier in leafy greens, rich in antioxidants. So as I mentioned, there's this bidirectional relationship between gut health, diet, nutrition, and the brain, and sleep as well. And so overall, when you have a balanced diet, you're able to get to those deeper sleep and that consistent sleep pattern more consistently. And again, this Mediterranean diet, there's some really cool studies called the MIND diet. If you're interested, I can send you some links to some studies talking about the epidemiological effect of these particular kinds of diets on brain health and on quality of life and everyday function. A few more things about enjoying eggs in moderation, especially if you have heart disease. Cholesterol is an issue with having too many eggs. Go meat-free when you can. Skip maybe a meal that's using red meat and replace it with beans and legumes. Watch our caffeine. I'll talk about that in a little bit as well. And then finally, limit our alcohol. Next, let's talk about sleep routines. Let's try to build a consistent sleep schedule. I know it can be hard to be like, okay, 10 p.m., I need to go to sleep, or I need to start ramping down to go to sleep. But I know that with everything going on in the world, with lifestyle factors, as I mentioned before, extrinsic and intrinsic factors that we can control, it can be hard. But let's try to be a little more consistent about bedtime, wake time, when you have your meals every day, and also control how late you eat. So if you're eating within 3 hours before bedtime, you're basically stimulating your body to be like, oh, you know, let's stay up for a little bit longer. And that might be because of some of the content that you're also eating late at night. Also follow the same pre-bed routine if you can. I like to read before bed, but other people might enjoy meditation, deep breathing, stretching. Putting on pink noise. There is some interesting just correlational research for now, but maybe some people can do some clinical trials research on the effect of pink noise, which is usually the sound of rustling leaves and waterfalls. Those are pleasant to the ears and are associated with being somniferous and inducing that sleep. But on the other hand, white noise, it might not be as relaxing. White noise is more of like that static, and it's made to mask sounds, but it actually might do more harm than good sometimes because there could be some disruptions happening when you're listening to that white noise versus pink noise. But again, that's based on more correlational research. And this bridge might sound familiar or look familiar to you, but light exposure, right? Natural light exposure is also very important for our circadian rhythms and sleep-wake cycles. It's crucial for regulating our internal clocks. We're more prone to sleep disturbances if we don't get regular vitamin D, from the source of the sun. And that could increase our risk for all these other kinds of health comorbidities, diabetes, obesity, depression. If you're not going outside to see the sun in general, those might also be correlated. And then outdoor light can boost vitamin D, which is also neuroprotective, by the way. And finally, bright light therapy is being explored for dementia patients, or patients with dementia, to improve sleep and reduce agitation. So this is where you have an artificial lamp that is providing that light exposure, especially if that person isn't well enough to get frequent light and being ambulatory to go outside in the first place, or living in an area where the latitude doesn't allow for frequent natural light exposure. If we have that artificial lighting, that can kind of present some kind of reprieve from that lack of natural light source. Then next, environment. We touched upon this too in some of the previous excellent talks. Turn off electronics. Comfortable, supportive bed. They say replace your mattress every 7 years. Hopefully we're all doing that. Dark bedroom, blackout blinds help. There is this huge correlation between, being able to close your blinds and staying asleep more consistently than people who have the blinds that are kind of peeking the light through. So make sure that you're buying those blackout blinds if you can. Remove mirrors because those reflect light, noise, light in the morning, aromatherapy, all those things that are conducive to good sleep. And then I also hinted at this idea that we should probably stay away from caffeine about 6 hours before we go to bed. I know that I'm very sensitive to caffeine as a pretty energetic individual, so if I have any caffeine after 3 p.m., I'm staying up all night. So yeah, avoiding those stimulants. So tea or coffee, right? Good in the morning, but by the time it's maybe 3, 4, 5, 6 p.m., depending on when you go to sleep, you might want to switch to something like chamomile tea that's caffeine-free or some other kind of herbal tea that you enjoy. And then again, touching upon the balanced diet, some of the things that we're eating are also impacting our sleep, especially those food items that are high in sugar. Napping. Napping is also, it's been interesting to talk about this because some people are either nappers or not nappers. I tend to see like a bimodal distribution. It's never like, oh, I'm in between. It's like either you're a napper or you're not. I'm in the not napper camp, but people do say, and there is a strong research supporting some correlational studies on napping and how it's conducive to better sleep in general and also for brain health. So it can curb disturbed nighttime sleep, reduce the daytime sleepiness. It can improve our mood by reducing stress and anxiety. And then if you're doing this at a regular time interval every day, even if it's on, for some of us that are working still, even if during the weekend, if you can find time to nap at the same time, that's more effective than randomly being like, oh, look, I have some downtime randomly at 6 p.m. Let me conk out a little bit before dinner. No, let's not do that. Let's try to maintain that regular routine. And then sleep medication considerations, I'll just touch briefly upon this. I get a lot of questions about, but what about, melatonin and these other kinds of sleep aids? If you are considering those kinds of things, consult your healthcare provider. Some of those medications that are not necessarily on the melatonin side, some of them are contraindicated with other medications that could cause falls, which is a huge risk factor for ultimate death, by the way, and is a leading risk factor for death in the United States, and also car crashes. And I know that some of us in this room enjoy driving, but if you're taking some of these sleep medications, that might not necessarily be a good thing, especially if you're still driving regularly. And then, yes, melatonin may be a suitable alternative, but I encourage everyone to kind of talk to their doctor about this before they commit to doing something like that as the alternative to some other kind of pharmaceutical. So that's the overall power of sleep. This is just the tips for healthy sleep, just a little schematic for you all to take note of in general. So let's try to reduce electronics, try to reduce our stress, different aspects of diet, alcohol, smoking, those kinds of things can interact with our ability to get deep sleep and getting to that deep stage of restorative sleep, I should say, because maybe some of you have experienced when you've had a full meal and you're unable to go to sleep and you're like, I'm not sleeping too well. That might be because of your body just trying to digest that food, and maybe there's some kind of inflammation that's happening in your body where your body is just not wanting to fall asleep at that point. And then on the other side, exercise, even if it's just 5 minutes a day, as I mentioned, there's studies saying that even a little bit of exercise is neuroprotective and good for your sleep. And then all the other impacts of the environment, your room where you're sleeping, those are conducive to getting that restorative sleep and ultimately protecting your brain health for your own longevity. And without further ado, thank you very much. Oh, thanks.
All right. Can you move to the front? Actually, I'm getting my 5 minutes of exercise coming to get your questions.
Okay, this is going to sound like a weird, quirky question, but I'm sure other people worry about this, and a lot of people believe in this, even if the medical community does not. What about all the electromagnetic things around us? We are electromagnetic beings. Like my husband has plugged in near where I like to nap something to like amplify the router, and I'm like, don't put that near me. So I was wondering if there's any evidence with sleep disruption with that.
Wow, I love this very interesting question. I will say this is a first. Very interesting. I don't have as much experience with that line of research and exposure to electromagnetic radiation or exposure to electricity or anything, but I do have some colleagues up at MGH, Mass General, and Harvard. So they're doing some studies on what's called 40 hertz gamma. You can Google it later, but there are some studies saying that if you're exposing yourself to either an auditory tone that's at 40 hertz or some of the techniques that some of the doctors were talking about with transcranial direct current stimulation and transcranial magnetic stimulation, some of those can pulse the brain at 40 hertz gamma at that frequency, and that frequency is supposed to entrain the brain to be more efficient and also clear out those toxins that I mentioned in the talk with the beta amyloid, and then maybe creating a better platform for your brain to have better sleep. So yeah, to answer your question, I don't know specifically about the router and being on the phones, if that's also impacting sleep, like through the electromagnetic waves, but there are some studies showing that there's some kind of non-pharmaceutical effect of the exposure of specific waves that may be good for brain health and sleep.
Excellent. Thank you. Oh, yep, here we go.
We've experienced photomodulation, and I'm a firm believer in red light therapy. And this has been an anxiety reducer for our family. Can you address that, and what are your thoughts on that type of at-home use, as well as we use a DOM who then articulates that through acupuncture and cupping? So we use red light therapy very aggressively and have for the last 10 years.
Yeah. I will say I have seen a lot of promising research on bright light therapy. As I mentioned in the talk, it's still being explored, but some of the early studies that I've seen are showing reduced agitation in patients with some of the neurodegenerative disorders, reduced agitation, reduced stress, reduced anxiety, and somewhat of like a more stable cognitive profile. So I'm a proponent for continued studies for the bright light therapy, and I would love to see larger studies in more broad populations, as we've kind of touched on, because a lot of the studies, unfortunately, are plagued by highly educated older adults that are wanting to participate, but we also want to tap into broader populations that might also benefit, if not more, from these kinds of therapies. Good question.
All right, thank you. All right. Last but not least, we have Dr. Terri Pease. She is going to talk to us about the unique challenges of Parkinson's disease caregiving, and I have her book here that I would like to raffle off, but we've lost a lot of our audience, so I'm going to hand these out to some caregivers. Does that sound good? That sounds great. Okay.
Thank you, Dr. Disbrow. And I'm just so happy to be here. I was excited to hear from Bernadette, that 5 minutes of Motown is going to change my life. So I've written that one down for sure. Hi, I'm Terri Pease, and I am so happy to be asked to be here because the world of Parkinson's disease focuses, as it should, on the needs and the experiences and the biology of people who have Parkinson's. But as I said to a group of doctors yesterday, and I want to say to doctors everywhere, for every hour that a physician can spend with your person with Parkinson's, with you, the person with Parkinson's. There are many, 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 many hours in which that treatment plan gets executed, gets carried out, gets followed at home. And that means that we cannot treat caregiving as being just an afterthought. A caregiver that I worked with said to me that when she went to the doctor with her husband who had Parkinson's disease, she felt like she was painted on the wall. And I will ask our friendly tech person up in the back how I can get my slides up. And I can do it without slides, so I'm not going to worry about it too much. I sort of know what I was going to say, but if you can get it up, that would be terrific. I'll give it like 2 seconds. When someone at home. There we are.
I'm taking your job. I'm coming for your job.
Uh-oh. Thank you, Dr. Disbrow. Yeah, when someone at home has Parkinson's, something has changed in your life too. And a lot of times, if you feel like that caregiver who feels painted on the wall, it's like, well, wait, hello, I'm here. I have something to do with this. And I just want to say that the reason that I feel like I have any right to be here among all these incredibly smart people with all these incredible research is that I worked for many years in trauma and working with people who were supporting traumatized people, and I won't go into those details, but I left that work because my beloved husband had Parkinson's disease, and his Parkinson's disease went from kind of calm and steady and relaxed, and we were going to go off and sail sailboats to a life where I was a caregiver to my husband with Parkinson's for many years. And so having been a caregiver after my husband passed away, I had all this stuff in my head, and I decided to write it down. And I'll tell you a little bit more about what I wrote down later. But what I want to start with today is by saying the one thing that I know for sure about you as a Parkinson's caregiver. And in fact, let me ask, how many of you would say, yep, that's me, Parkinson's caregiver? Good, I'm glad you're here. And some of you are people with Parkinson's, people living with Parkinson's disease. And if you're a lucky person with Parkinson's disease, you have somebody who has kind of stepped up to say, when you need me, I'm here. So I'm talking to both sides of that. And then if there are other people who take care of Parkinson's patients, please pay attention to caregivers. But the one thing I know for sure about Parkinson's disease caregivers is that you are not afraid of hard work. It's not the hard work that worries you. There are things that worry you, but the hard work is not it. You already know that you are going to be in charge of medication management at some point, helping to get the meds counted out, laid out, scheduled, delivered at the right time, understanding what those instructions were. That you're going to be in charge of encouraging exercise. What have we been hearing? Exercise is medicine. Those really smart people down at the University of Florida are telling us, Dr. Michael Oken and his teams are telling us, exercise is medicine for people with Parkinson's disease. And so you are the exercise cheerleader, coach, encourager, nag sometimes. And avoiding falls is another thing that you as a caregiver know is part of your responsibility and part of the work that you're going to do, which is to help keep the person with Parkinson's on their feet. And I mean, I've seen that here today, and I saw it in my own life, and you see it everywhere, that a Parkinson's caregiver does a lot of, like, plant your feet, help your person, because Parkinson's is making it really difficult to stay on your feet. But you, as a caregiver, help with that. Those things are not surprises. And when I asked a group of Parkinson's caregivers to tell me, like, what remains troubling to you? What surprised you? They said, first of all, I can manage supporting my loved one with Parkinson's, my person with Parkinson's, with managing the tremor and the motor stuff and the meals and all of those things. You know, I can do that. And I'm not afraid to do that. What I can't manage is the indifference. And this is kind of an unspoken reality of Parkinson's, that Parkinson's influences our relationships. I know no doctor ever told me he will be different with you. He will forget and lose track of the love he feels for you, and it will become much more one way. I'll tell you later a little story about that. Parkinson's caregiver said to me, I'm always on. was in the airplane coming here, and I dropped some of my papers, and the person who was sitting next to me saw Parkinson's disease on her. We started talking. He asked me what I was coming here to do. And then he said, be sure you tell those doctors that it's 24/7. Because we as Parkinson's caregivers who love and want to do right by the person who has Parkinson's have to be kind of always the awareness in the background, day and night, and it's hard work. To you people who are people with Parkinson's, living with Parkinson's, I'm not saying these things to make you feel bad. You didn't say, yep, I volunteered for Parkinson's, did you? I don't think anyone volunteered for it, right? But you got stuck with it. But it's important to notice that your loved one has stepped up with you. And that is hard work. And just, look at them, say thank you. I'm not asking you for much. Parkinson's caregivers tell me nobody told me this was coming. Nobody prepared me for this. And that makes it really hard, because what I hear from caregivers when I encounter them all sorts of places, they will say, I didn't know that this was part of Parkinson's. I didn't know that these changes were not because I'm failing as a caregiver. And what a terrible feeling that is. You're trying to be a really good caregiver because you love this person to pieces and you want to do well by them, but you're not, first of all, you're not doing the magic thing we all imagine, which is make his Parkinson's go away. In the back of your mind, isn't there a part of you that thinks if I do it just right, their Parkinson's will go away? Well, it's not going to happen, but we wish it because we're human. But no one prepares us for things, and then we think, if this showed up and I couldn't make it stop, it's my fault. That's a really hard part of Parkinson's caregiving that people don't really talk about. And this last thing, I feel so alone. Parkinson's is very isolating for the person with Parkinson's because Parkinson's disconnects you from your own ability to like people. Does that make sense? It kind of disconnects you from your own way of being with other people in the world, and it takes a little extra effort to feel friendly, to feel that there are people who are friends to you. Parkinson's is working against you for that. And so people with Parkinson's and their caregivers feel alone. Does that sound familiar? And caregivers struggle. What makes it hard? Things like this. I'm always solving problems. And again, with a lack of information, with nobody telling you this and this and this, and no one giving you, sort of guidebooks or information, you're having to make it up. As I sometimes remind doctors, almost every Parkinson's caregiver you meet is a beginner. You're doing this for the first time. And so it's not surprising that you feel a little bewildered and you're solving problems that you've never had to solve before. You feel invisible, as I said, no one sees me, painted on the wall. I mean, that person said that to me, and it clearly stuck with me because I repeat it all the time. Lacking a map, there's no road map. A couple reasons for that. There's no road map because it's not a one single pathway from here to there. Every person's Parkinson's has its own particular route, and so it's really hard to know, okay, this is what's happening. What stage are we at? What's coming next? Caregivers often ask that. What stage is my person? And yet, the doctors are reluctant to use stage language because it's not cancer. It's not other diseases. It's not even bone healing, where, your kid breaks their leg, you kind of know how bones heal, you know what to do, you kind of know when it's done. Parkinson's is not like that. There's no roadmap. And people feel unprepared. And something that I discovered, and I think many caregivers agree with, is that having Parkinson's disease in your family, when someone in your life has Parkinson's, it's like having an intruder in your household. Who's this stranger? And I say sometimes that Parkinson's disease is like not only an intruder, but a thief in your house. I'm going to take a minute to talk about the reason that I picked the word steals, S-T-E-A-L-S, to describe the Parkinson's intruder. Because Parkinson's steals sleep. It makes for restless sleep. It makes for disruptions to get up because of incontinence, getting up to the bathroom on time. I mean, all of us, most of us, when we get older, we have to get up in the middle of the night and take care of business. But for sometimes when it's helping a loved one who's having difficulties with incontinence, that means we're getting up when our own bodies are not saying, wake up. And so sleep is disrupted by Parkinson's. That's the S. Parkinson's affects thinking and understanding. And again, maybe nobody told you this, that it's going to make your thinking a little slower, and it's going to be harder to solve problems. And that remote that you used to be able to just do in your sleep, you don't remember how to do it. And it's rotten that Parkinson's does that, but it does, sometimes for some of us. Parkinson's affects eating and elimination. And so we all know about the struggles with constipation and how important it is to not wait till you've got some constipation and then treat it, but to have some kind of a regimen. And their Parkinson's caregivers probably have 83 ways to help keep someone's internal system regular. But to have a routine for bowel maintenance and constipation maintenance, I think, is really important. But Parkinson's steals the things that we expect to be able to do, to eat and eliminate without having to think about it too hard. Parkinson's, as I've said, steals affection and empathy. I'm going to tell a kind of difficult story about my husband, except it has a really happy ending. Halfway through our Parkinson's journey, and he'd had maybe 17, 18 years of Parkinson's, maybe more at that time, I came home from the doctor with a really scary medical diagnosis, the kind that makes everyone go, oh, Lord, you poor thing. And I can tell you about that because I was very lucky and they were able to do one little magical procedure and then send me home, and I'm now fine 8 years later. So it was not a big deal. But I didn't know that, and he didn't know that. And when I told him about it, he said, I know I should care, but I don't. That's kind of hair-raising, isn't it? And yet, my husband was a lovely person, extremely good man, had British boarding school manners, so he was a very, very good boy, if I can say that about him. He knew how to act. But he couldn't feel worried for me and my scary diagnosis, and that puzzled him, because Parkinson's took away his ability to feel empathy for me. And I know he loved me, and I never questioned that. But I also knew that it was really hard for him to feel connected to me, because Parkinson's had stolen his ability for, or at least worn down his ability for affection and empathy. L, Parkinson's steals learning and remembering. I asked you yesterday, take the dog out every day before 3 o'clock. Sure, I will, but it doesn't stick. That promise doesn't stick. That routine doesn't stick. And so a person's ability to learn and to remember things is also compromised, taken away. You're undermined by Parkinson's. And S, sex and other impulses. No doctor said to me sexuality is going to be affected by Parkinson's. Now, Parkinson's is just weird. For some people, the sex drive seems to go through the ceiling. And for other people, the sex drive drops, down below the basement. And there's no real predicting about that. Medications play a role in that. I'm not a physician, so I don't try and sound like an expert about that. But what I do know is that if you see sudden changes in sexuality in somebody who was kind of, predictable, we get older, we get a lot more predictable about that stuff, I think. But if stuff changes, talk to the doctor, because Parkinson's affects sex. Specifically dopamine agonists, medicines that are supposed to, boost up the effectiveness of dopamine. Medications like Cinemat, and that's what the edge of my medical knowledge. But it affects the ability of the person to regulate sexuality and sexual impulses. And so you hear people doing some really surprising sexual behaviors that are not because their morality has changed or their heart has changed, but because their brain and their body are operating in ways they can't really manage. But it's not only sexual impulses. It can also be spending, the person who's on QVC spending $1.5 fortune, or punding. Do you know what punding is? This is a little survey just for my own edification. How many of you know the word punding? No? Punding is the impact, an impact of Parkinson's disease. It is repetitive, almost obsessive, organizing, cleaning, fixing. In our house, it was little bitty house repairs. I'll never forget, 4 o'clock in the morning, my lovely husband is on the top of a ladder like this. And he had no business on a ladder. And yet he's up there changing a light in the ceiling fan or something at 4 o'clock in the morning, and I'm there going, can we please go to bed? I'm so tired. Can we please go to bed? Because, I was tired. Sleep. Where's Dr. Byrne? I needed my sleep. he couldn't hear me and process that and notice that it was 4 o'clock in the morning and notice that that light bulb could be changed by somebody else or at another time, and that if we went to bed, we didn't need that. None of that thinking was there, right? But he also, there's a little wooden frame on the front of our front door. It's meant for holding mail. That man built this, sanded it, installed it, painted it, didn't like it, took it apart. Sanded it, repainted it, put it up, didn't like it. More times than I could count. That's punding, doing and doing and doing with the hope or with the habit of it being productive, but it ends up not being productive. It can be rearranging the socks in the drawer. It can be, oh, I'm blanking on other examples of punding. Anybody here have an example of something that they've seen? Sorry? Buttons? Sorting them out. You're describing a bag of buttons. My mother had a great jar of buttons. And he'd put all the red ones and all the blue ones and all the greens. And then, nope, they're not right. And they put them all back in the jar and then do it again. And do it again. You know, and it can drive us crazy. What are you doing? That's not productive. You know, and yet that punding is not at all uncommon in Parkinson's disease. And clearly nobody in this room has heard of punding. And it's something that is one of the other odd impulses. Gambling. It makes people very susceptible to online scams. I've got $40,000 for you. Just send me $50,000 and I'll send you back $40,000. You know, that kind of nonsense that people come on your phone. People are much more vulnerable to those kinds of things because impulsivity is unregulated. And if you haven't heard of this stuff as a caregiver, if nobody's told you this, how can you help? How can you feel adequate? How can you avoid feeling like you, the caregiver, have failed? So Parkinson's can be a thief, and this is the one thing I want to say. You're not afraid of hard work, but you can certainly be afraid of things that you don't understand. And so this is why I also say that Parkinson's caregiving is about managing change. If I tell you, you've got to deal with extra laundry from now until eternity, you'd go, oh, God, all right, I'll go buy an extra box of Tide and move forward. I'm old-fashioned. I don't like liquid Tide. My Tide comes in a box. It's a white powder. But it's not about that. It's about managing change, about the fact that things change all the time. And I'm not watching the time at all, so how much time do I have left? 10 minutes, 5 minutes? Somebody help me out here. Routines change. You think, okay, we'll have breakfast every day at 8:45, except the day that your person with Parkinson's just can't get out of bed, or the day that they decide, I don't want to have breakfast right now. So your routine is all shot to pieces. So routines are constantly changing. Your role is changing. I can't tell you how many caregivers have told me about how we used to, he did these jobs, and I did these jobs. He did the driving, I always managed the finances. He did the garden, you know, I did the interior repairs. Whatever, your particular recognizable roles in your relationship. And I'm talking largely to couples, but to any family setting where there's a person with Parkinson's, those roles change. Partly because the routines change, partly because the person with Parkinson's may not be able to do all the things they once could do, may not be as interested in the things that they once were cared about, because Parkinson's is stealing away all of that motivation and energy and caring. Your life plan has changed. We're going to get those kids out the house, and then we are going to get an RV and travel around America and see the sights, except not. For us, it was the sailboat. I should have a picture of my sailboat. We bought the cutest little sailboat. My husband loved to sail open boats, you know, not anything fancy, the kind of thing you may have sailed at summer camp. And we got this boat, and we got new sails for it, and we were just like going to be the fanciest people you ever met. We sailed that boat twice. The day the person who built it for us brought it up to the house, and the day that we went sailing with a neighbor and realized we cannot do this anymore. Right? So that life plan, which was really lovely, it was a lot of fun to do that planning, but we never got to carry it out. It changes your expectations. What can you expect of the person who has Parkinson's, and what can they expect of you? I encourage people to build a caregiving plan together. And I help people do that because that way you can talk to each other early on. What does a healthy caregiving experience look like to you? What are your expectations of me as your caregiver? What do you think I should do? Can I tell you about things that I may never want to do? Simple example. My husband couldn't manage his foot care on his own. And I helped him with more unnameable things than you can imagine, or if you're a caregiver, maybe you can imagine them, but I could not deal with feet. And it's a small thing if it doesn't bother you, but it was just one I couldn't do. Thank God there's a lovely podiatrist down the road from us. But just knowing that that was something I couldn't do and being able to talk to each other about it meant that it didn't become a battle between us. It was us working together as a Parkinson's couple, caring for each other. And that helps to sustain the caring for each other, especially as Parkinson's makes it harder for your loved one to do their side of maintaining the relationship. Not because they don't want to, but because they're being robbed. What did I leave out? Emotional tone. Parkinson's flattens out emotion. Does that sound familiar? And yet the person with Parkinson's may be feeling it inside very, very strongly, but they can't express it. They're disconnected from it. This one has its own circle, and if I were fancier with the PowerPoints, I would have made it grow so that you would see that the thing we lose and that scares us most as caregivers is when we start to feel disconnected from our loved one with Parkinson's. Because Parkinson's takes away the routines, the regular way of give and take that any successful longish relationship develops. Whether you are madly in love with each other or just holding on for dear life, both things happen, right? You have expectations about what is our connection, how do we do relationship, how do we do family, how do we do marriage. Parkinson's makes that harder. And so you have what I think caregivers, and what I know caregivers can do, because I've seen it happen, is to learn to reconnect and reconnect and reconnect with the person with Parkinson's as Parkinson's changes them. Learning to love the person with Parkinson's as they are today. It's really easy to get mad at your person with Parkinson's and say, you never treated me like that before, how dare, you can get into that state of mind, but what is that? It doesn't serve you, and it isolates you and the person with Parkinson's. A person with Parkinson's can get the notion, because as they feel disconnected from you, they get a notion, this is how I interpret this anyway, you're having an affair with Joe the butcher down the road. And somebody's laughing, I suspect because you may indeed have seen that. Accusations of infidelity are surprisingly common in Parkinson's. And it feels as real as anything. And yet, it has nothing to do with the reality of relationship. And if that becomes a battle between you and your person with Parkinson's, how dare you? I love you and I clean up at it, all of that. And they're so certain. I know you're having an affair with him. You were downstairs for 7 minutes and you were getting it on with him in the kitchen table. I've heard exactly this, right? What they're actually saying is, I missed you. I missed you and I couldn't find you and I didn't have the brain capacity to figure out where you were and come find you. But it comes out with, you're being unfaithful to me and you're, getting it on with Joe. And so your connection can be so fragmented if you aren't given the information to say, how do I stay connected? How do I stay engaged? How do I re-love? Is that a word? I made it up. Can I re-love this person as Parkinson's is changing him? Just the other day, we had Valentine's Day. Valentine's Day can be particularly difficult for couples in Parkinson's because if you've had a routine where flowers and candy or whatever, that gets lost. One of my favorite stories about caregiving and Parkinson's was someone who was in a community that I was in. She went and bought balloons and chocolates and flowers. And on Valentine's Day, she took her husband and her shopping bag and she steered him to the front door and she said, Sam, these are my flowers. This is my chocolate. These are my balloons. ring the doorbell, and wish me a happy Valentine's Day. And then she went back inside the house and shut the door. Now, she's peeking out the window, right? She's not crazy. She's like, is he okay? But the photo she shared of his smile when he rang the doorbell and she opened the door and he was able to say, Happy Valentine's Day, was such glue for their relationship. It was relearning the love. And caregiving is hard. When I said you were not afraid of hard work, I didn't mean that it wasn't hard. But what I did mean is that many, many, many people are equal to the challenge if they understand what's going on, and they have some strategies, and they have some plans about what to do. Because otherwise, it feels all very personal. The apathy that I've talked about, the withdrawal and disconnection, the flat emotions. And yet, I want to leave you with the fact that this apathy doesn't mean lack of love. This withdrawal is not being lazy. The executive capacity to be able to do the simplest tasks. I just told you yesterday how to get the dog fed. It's not there. You have to say it again, lovingly, not impatiently. It's not easy to do that, but it is doable. And the flat emotions don't mean not caring, because these things that we see are neurological, not moral. And if we understand that all of these changes, these behavior changes and these emotional changes and these engagement changes are a result of the disease and not a change in the person themselves, that strengthens us as caregivers, I believe. I think we're going to need to stop, but I'm going to just tell you that one of the things that I want you to think about is that you can ask your person with Parkinson's, may I have your permission to be your caregiver? Ask for permission to be the caregiver. And I think in doing that, that's another piece of cementing the relationship. I just want to say very quickly that I have a book that I mentioned. You can get it for free on Kindle. You need me to go back one slide? That QR code is not the one that I want to use. It wasn't working properly, so you can just ignore it. That's why I went flying by it. You can just go to my website, terripease.com, and you'll see a big pink oval which tells you how to get it. Sorry for going over time. Thank you.
Thank you for coming.
I'm happy to. I couldn't hear you, I'm sorry. Guilty. Of all of that. Say more. Just the feeling of disconnection and... I'm the Parkinson's. Okay, you are a person with Parkinson's, and did you know that Parkinson's was doing these things to you?
No. I was always meticulous about things, and Parkinson's made me worse. I lose track of time, the sleep issue. I stay up all night some days, some nights, because I'm so close to finishing something. I just need to finish it.
Just let me keep doing it.
But it takes so much longer to finish anything now.
Yeah.
So.
Sometimes your partner might be able to say to you, I know you'd like to finish this, but tomorrow is coming.
I try.
I wish that on for all of you. Other questions, thoughts? There's a question here.
I really appreciated the information about punding. I really appreciated the information about punding because I've been doing that and didn't know I was doing it.
Yeah.
And, you know, it's like you get something out and you try working on it to get it going, and then you find something else that you've got to do this first, and we get that but first syndrome thing going. And what I end up doing is starting out, putting things away, sorting them, and trying to organize it. And what I end up with is more piles in the middle of the floor than I ever had before.
Right.
And there's nobody around to say, do this, and it really would help if I could just say, you do that, you do that, you do that, this needs to be done, because somebody else could definitely do it better than I'm doing it. But you don't think about the fact that you're going to make things worse instead of better.
And you can't really discern that necessarily because Parkinson's is obscuring your ability to sort of sort those details. And sometimes I try really hard to behave myself, but there are times that I just want to use the dirtiest word I know and say something really ugly to Parkinson's, not to a person with Parkinson's, but to the disease. In fact, I heard Michael J. Fox, our mentor and person who funds us, say that on TV the other day, F Parkinson's, because sometimes it deserves that. Any other questions or comments?
Strategies on burnout for the caregiver.
Well, the first strategy is burnout prevention. If you know all this weird stuff is coming, then self-care means that you don't wear yourself down to the ground and then say, oh, I need to get to do better. From the very beginning, integrating your own well-being into Parkinson's care is critical because burnout is like the end of the rope. It's like when you've used up every bit of energy you have. You're going to need a lot of energy to be a Parkinson's caregiver. But you also, and it doesn't mean just bubble baths and go to the spa. It also means I'm closing the door. I don't care. We just had lunch. You may be hungry. I'll be down at 4. There's a cool kind of timer called a time timer, which is an interval timer, which when the timer runs out, I'll be done. You know, I'm trying to do that much too quickly, but yes, there are strategies, but the first strategy is don't wait. And don't feel like you have to be some kind of magic, perfect fixer of Parkinson's. That's not your job. Obviously, I could babble on about this stuff forever, Liz, so shut me up whenever it's time for us to stop. Thank you. Your mic isn't on, but.
There we go. I love what you have to say, so thank you so much.
I love caregivers.
Yeah.
Caregivers.
I do too. Thank you.
Thank you all for coming. We have made it through the program, and if there's anyone here who would like a t-shirt, and if we still have your size, please just check and see. You all are the Parkinson's champions. You've made it to the end, and everybody deserves a shirt. So please check, and if you'd like one, pick one up down by the registration.
A lot of people had the slides and the information on their computers. Where can we get that? Because I didn't see any place to do it.
We will post all the slides that we have on our website, and we have all of your emails in our registration, so we can send you an email if you would like. We'll have to figure out a way for you to unsubscribe if you don't want to be on an email list, but we can create that and provide this information and information about other events that we will have in the future. Our website is lsuhealth.edu/Center for Brain Health. LSUHS, yes. LSU Health Sciences, I think, .edu. Basically, if you Google LSU Center for Brain Health, we'll come up, and that's our website. There's actually several ways to get there, and there's too many ways to get there. Thank you.